Good morning, everyone, and welcome to the Health Committee meeting for the County of Renfrew. It is Wednesday, November 15th, 9:30 a.m. I am calling the meeting to order. As we gather this morning, I wish to acknowledge on behalf of committee and our community that we are meeting on traditional territory of the Algonquin Nation. We thank the Algonquin people and express our respect and support for their rich history. We're extremely grateful for their many and continuing displays of friendship. We thank also all the generations of people who have been careful stewards of this land for millennia. Ms. Chaput, has the roll been called, please?
Yes, Chair, we have quorum.
Thank you. I would now invite disclosure of pecuniary interest, and if any, the general nature thereof, please. I recognize none. I'd now seek a motion to adopt the minutes of the meeting held October 11th, 2023, please. Moved by Councillor Nicholson, seconded by Councillor Weir. Any questions, comments? All in favor? They are approved. Thank you. With that, we do have a delegation. Very pleased to see the delegation this morning. I would invite Chief Nolan, if you would be so kind as to invite our guests and welcome our guests, please.
And so on. Thank you, Mr. Chair. Through you to members of the committee, it's an absolute pleasure of mine to invite Ms. Judy Hill, Executive Director of the Petawawa Centennial Family Health Centre, and Dr. Jonathan Fitzsimon, Medical Lead for RC VTAC, to provide an update regarding the Integrated Virtual Care Program. And we also have some very good news this morning in terms of an award that was achieved by the incredibly hard work of their team. And we'll start off with Dr. Fitzsimon providing an overview of the program. So welcome to you both. And while we talk about these chambers a lot, and you've been in these chambers in different occasions for different reasons, it's absolutely our pleasure to hear the progress that you've been making in the integrated virtual care space. So thank you, Dr. Fitzsimon.
Thank you, Chair. Thank you, Chief Nolan, for the introduction, and committee for inviting us to talk to you today. It's actually 2 years since I last presented to Health Committee. We've been busy in that time, but I wanted to start today's presentation with the last slides. I think the battery is dying on this one. Next slide, thank you. The last slide that I gave at my presentation 2 years ago, just in case you can't read that quote, Dr. Affleck said that we have to change from an analog version of healthcare to a digital version. And I think in Renfrew County, we've made great strides over the last couple of years of doing that. We've used use of virtual technology for virtual care. We've used digital equipment through the primary care network and other resources. We've started to introduce online appointment booking. So we've made great steps with digital technology in our healthcare system. Still a lot more to do. I think the other slide I presented 2 years ago was the problems that we face. And I could have just copied and pasted it into today's presentation because many of them remain very similar. We still have thousands of unattached residents of Renfrew County. We have more physicians who will retire in the next couple of years. There's been incredible efforts to recruit physicians, but it feels like a lot of that hard work was completed to essentially stand still in terms of the level of unattachment. Still massive over-reliance on the emergency departments. But of course, VTAC is robust, up and running, offering thousands of appointments with a family doctor supported by paramedics every month. And many tens of thousands of residents have benefited from VTAC. We keep the same simple system with VTAC. You call, you speak to a trained medical receptionist, you have an appointment with a clinician, usually that day. Most of the time, your issue is dealt with. Sometimes we'll organise and help you navigate to other investigations or care, and very occasionally we'll escalate the care if necessary to emergency care. The numbers on the right show you since March 2020 when we initiated VTAC, just the sort of output of clinical care that we've been able to offer to the residents of the county. And then the numbers on the left show a typical, in fact, they're October's figures. And I draw particular attention to the fact that 70 to 80% of encounters with VTAC on any given day are to people that are unattached. They don't have a primary care provider. And October's numbers were actually 27% of those that had an encounter with a VTAC physician indicated that without VTAC they would have gone to an emergency department. October, we were actually under 2% of those physician encounters being directed the patient to go to emergency or call 911. So we're keeping 1,000 unnecessary ED attendances out of the hospitals every month. There's really good evidence that patients appreciate virtual care, and this is not just what we've done locally to sort of evaluate that, but Canada-wide, Canadians appreciate many of the benefits that come from having virtual care options. And I think any program that has an overall satisfaction rate of 90% is one in healthcare that we would deem to be a huge success. But look, we wanted to go further. We wanted to go beyond VTAC, this acute episodic care, this calling a doctor and having access to a family doctor the day that you've got a problem. Sure, it's fantastic that we can give more people access to a family doc. It's fantastic that we've got this synergy of having paramedics available locally to provide in-person support to those doctors working remotely, giving virtual care. But it's not comprehensive, team-based primary care, which is what we aim for all of our residents. And so very early on, literally in the first few weeks of VTAC up and running, it occurred to me that the benefits of VTAC with a family doctor, and we can pull in a whole pool of family doctors now from all over the province, not just people that can physically relocate to the county. Having that pool of physicians supported by local paramedics seems to be working really well. We're giving a lot of people access. A lot of people are happy with what's happening. We're protecting EDs and 911 paramedics. So why not use that concept and go a step further? Attach people to a family physician who works predominantly remotely, but is embedded within a local family health team. So now it's the whole team of allied health professionals, nurse practitioners, dietitians, respiratory therapists, counselors, that whole array of allied health professionals providing team-based care, and a named family doctor who has that overall long-term responsibility, building that patient-doctor relationship with previously unattached residents. And I come back to that first quote about using sort of digital resources. We learned from VTAC that we could equip the paramedics, we could upskill them, we could give them some new equipment like digital stethoscopes, digital otoscopes, so that when they did feel like I need a physician input here, this is an opportunity for us to keep somebody out of the ED, to avoid a transfer. Using the digital equipment with a physician on a video link means that you have this hybrid version of assessment, paramedic with the patient in person, physician working remotely, and we brought that sort of benefit to the IVC model, where now it could be any of the healthcare providers. It could be a medical office assistant, somebody who knows how to hold a digital stethoscope, somebody who can help with that examination. So the physician's on video, leading the encounter, caring for their patient, assisted by a nurse, a medical office assistant, another allied health professional in the local clinic. And it could just be as simple as somebody setting up the technology. Here's the exam room, come to your clinic, cameras on, you're good to go, you have your appointment with your doctor, I'll leave you alone now. And of course, all of those other resources, programs, things that people that have access to a family health team are aware of, now these residents who now have a family doctor also have access to the full array of comprehensive team-based care. I might need, if you could click next slide for me, please. Perfect. So the College of Family Physicians of Canada a few years ago produced a blueprint called the Patient's Medical Home, which many of you may have heard of, which is essentially the gold standard that we should be aiming for primary care. And I draw your attention to pillar number 6, comprehensive team-based care with family physician leadership. That's what we're aiming for through the integrated virtual care program. We leverage VTAC. So if you're unattached and you're calling VTAC because you've no other option, you're trying to keep out of the emergency department, that's how we can identify people that are in need. And that's, if you like, how we generate our list of patients we can support and offer care through the integrated virtual care program. And we also offer attachment to IVC to their unattached household members. And that has the added benefit of keeping a more balanced practice for our IVC doctors, so that they get a range of age and sickness and health levels. Next slide, please. So patients are rostered, they're rostered to a named physician. The physician works predominantly remotely. They're embedded in the local family health team, and they're connected to all of those other resources in the community, be that the community paramedicine program, the midwifery service, the regional palliative care team, all of those other local resources that anyone with a doctor could access, but anyone without a doctor often can't. Now they can. And we have this sort of mantra that patients can access care in person, at home. They can have it virtually or in person, and they do so and they make that decision based on their individual preferences and clinical needs. Next slide, please. We've done a lot of work evaluating. I've given many presentations at both provincial and national conferences. We've published nationally and internationally, evaluating based on the quintuple aim framework of patient experience, provider experience, costs and clinical outcomes, always looking through that equity lens and from our perspective, that means giving more people access to primary care. Judy, do you want to?
Good morning. I was introduced to Jonathan in the summer of 2020 after one of my full-time on-site docs developed a long-term illness, and we had to come up with a plan fast to deal with those 1,450 patients. The IVC concept was born. Next slide, please. This is what we've done to date. 3,249 patients have been attached to a named family doc. 10,000 appointments with a family physician, 5,800 or so appointments with an IHP, an interdisciplinary health provider. So that could be a social worker, registered dietitian, nurse practitioner, pharmacist, respiratory therapist. We've done cancer screening, and we're running around the 70% of our, which is on par with or above Ontario's average for cancer prevention screening. 477 pap smears, 460 colorectal cancer screenings, 279 breast cancer screenings. We've had 56 smoking cessation referrals. Next slide, please. So we improve equity and access to care. Our patient satisfaction is 88%. That's pretty good. You can read the comments on the bottom of the slide. They're excited to have a doctor who will care and listen to my needs for body and health. The process was very quick, and everyone was very helpful and friendly. This has been one of the best experiences of obtaining a doctor, including the initial contact and follow-up appointments. Excellent service. Thank you. Next slide, please. So this summer, we submitted an award to AFTO on integrated virtual care. There were 10 projects nominated, and we won. We have been recognized by Ontario Health, Health Excellence Canada, the Ministry of Health, and actually the AFTO plenary speaker, Dr. Tara Kieran, who is the DFM chair of Toronto University, referred to us in her keynote plenary. So We're moving beyond the AFTO award to 2 satellites in Renfrew County. We've started one at the West Champlain Family Health Center in Pembroke, and we've just started on November the 1st, a satellite service in Deep River. We rescued 1,100 patients that were unattached as of October the 27th, and we have found 4 doctors to attach those patients. So there was a 4-day interruption in service, but that's all. So these patients have been attached to a named family doctor to have comprehensive primary care supported by family health team services. Next slide, please. And that's it. Would you have any questions for Jonathan or myself?
Thank you very much, Judy. Congratulations first on the award. As someone also that was for an extended period, I do have a family physician at this point, but for someone that was unattached, I can't imagine that the 4 days was an insurmountable obstacle for them. I think in future presentations, you can probably just disregard that proviso. I think that they were probably ecstatic nonetheless. Open the floor to any questions or comments, committee. Councillor Lafreniere.
Just a comment. I want to commend you for the great work you're doing in our community. It helps so many people. I am unattached when it comes to a doctor, that is. But I did contact the Petawawa Centennial Family Health Team to do some cancer screening recently, and I was really pleased that they could actually book an appointment for me, so I'm all booked up, because it's been years since I lost my family doctor, so it was getting concerning, I should go, and so I want to commend them. They were great to work with. My daughter obtained a physician through your organization, and she was expecting a child at the time, which was really good news for us, so keep up the good work. I look forward to what this turns into, and I want to say that I commend our paramedics too for the work they're doing with your organizations, and yeah, we can just keep moving forward. Thank you.
Thank you. Councillor Nicholson.
Chair, may I just add one last
absolutely.
quick comment? Councillor, thank you for your comments there. And I might just say that literally on the way up here this morning, Judy and I were meeting with a regional program. So the regional cancer lead in Ottawa has reached out to us to say, look, how can we mesh our programs here to help unattached patients get cancer screening? So they're aware of what we're doing with VTAC, with IVC, and how that's embedded within the Renfrew County Primary Care Network. It's really spreading the word of what we're doing here, and now it's really interesting that Ottawa-based programs reach out to us to see how they can learn from us. It really is a bit of a role reversal over the last few years.
Further to that, I did call the health unit because I was concerned that I hadn't had any exams, proper physical exams in years. They were the ones that told me you can book an appointment, and I was just ecstatic. So that was great. Thank you.
Thank you, and thank you, Dr. Fitzsimons for the clarification on that. And I think that, increasingly, I think that we are becoming known as a center of excellence at the cutting edge, certainly of technology and adaptation. Councillor Nicholson.
Thank you, Chair. I'll echo the points made by Pembroke. It goes without saying that we couldn't thank you enough for everything that you do for our residents. I'm interested, though, if you can help me appreciate what some of the obstacles have been to get you to this point, and what are the future obstacles that you need to be addressed in order to take this as far as possible.
Doctor.
So I would say those previous obstacles and future obstacles have reversed over time. So initially, the obstacle was getting enough physicians. We had to get physicians, even with this bigger pool, even now being able to utilize anyone, whether they were Toronto-based, Ottawa-based, or anywhere in the province, that was still an issue. We had support from the ministry and from Ontario Health. We had funding to be able to initiate it, but it was still a lot of work to get physicians. Over the 2 years since I last presented, we have done a lot of work based at the Petawawa Centennial Family Health Center on developing the workflow and protocol for onboarding patients, getting them through that process of being long-term unattached in many cases to attached through the IVC program. Where I would say we're at now is not 100% the reverse, but I have a steady stream of physicians who reach out to me. We've worked very hard on developing networks to identify physicians that this model works for them in their personal and professional circumstances. And so we've been able to bring more and more physicians on board. We now have 12 individuals at Petawawa alone, plus the 4 at Deep River, plus 1 at the West Champlain site. Now, they all work part-time, but 17 individual physicians is pretty impressive recruiting by anyone's standard. The challenge now is the funding to do that work to bring the patients on, because it's time-consuming. You need to sort of prepare them for this program, prepare their records, get some of their history, have the nurse practitioner support, which is over and above the typical family health team, to help the physicians do in-person exam when it's needed. Because about 1 in 5 times, the physician says, I can't do this virtually, I need someone to feel that lump or move that shoulder or do something with hands-on. So that has a cost implication, and so for the IVC program to grow, it's now not so much the physician being the block, it's making sure that we have the dollars to support the growth of the program. But I would say this, to finalize this point, is that we have been very meticulous over the last 2.5, 3 years of making sure that we never grow this program more than we could cope with if all of our funding stopped. So with April the 1st, the ministry said no more additional funding for IVC. We would not be telling any patient or any physician, sorry, your time's up, you don't have a doctor again. So we've always grown at a level that we can maintain, but if we want to grow more, we will need additional funding.
Thank you. Further questions, comments? Councillor Murphy.
Thank you, Chair, and through you. I maintain from your presentation in 2021 how eerie it is that Dr. Affleck noted that virtual technology was going to be the future of healthcare right before COVID hit. So, and then of course VTAC was born out of necessity from the pandemic. But I also think one of the bubbles, I avoided an in-person visit to a doctor and/or ER. That is very interesting to me because I think sometimes if you're feeling really yucky, and I know Dr. Fitzsimons, that's a medical term, when you're feeling really yucky, you don't want to go to your doc and you don't want to go to the ER to find out that you have the flu. But I do think something like that, I recently had shingles. And all I had to do was sort of take a photo of my rib cage, and VTAC said, yeah, that's shingles. All right, good enough. So I think that there are those times where you know that you should go, but do I really want to go now that I've got this resurgence of chickenpox and put myself in a waiting room with people that are sneezing and coughing? So I found some of these bubbles, we now have the presentation. I found some of these bubbles very interesting. Thank you.
I think you raised a really valid and interesting point, something that I find myself referring to a lot when I talk with colleagues and policymakers. Sometimes the pushback is virtual care isn't for everyone. To which I say 100% agree, which is why we have focused so carefully and so diligently on the hybrid model, that it's virtual care with in-person support, whether it's more limited with VTAC, where we have paramedics sort of in-person support available, or whether it's more extensive with IVC, where we have the whole family health team available for in-person support. But my pushback is this: virtual care isn't always right for everyone. Neither is in-person care. You talk to the person that has to take half a day off work to get their elderly relative with dementia ready to come to the clinic, pay for parking, figure it all out. Everybody's stressed at the end of that appointment. And it was something that could easily be done with a digital photograph and a phone call from home. So I push back on that criticism or that critique, if you like, by saying I agree with you. In-person care virtual care is not right for everyone all of the time. But I think your point is super valid that neither is in-person care. The combination is what makes it so good.
If I may, as a supplementary, I'm also taking up ED time. I'm taking up a nurse, an intake person, a doc, whoever I have to see. I've now spent healthcare dollars that didn't need to be spent, period, because there was nothing they were going to do about my shingles when it was 48 hours later and I missed the medication window. So it just makes so much sense. It took literally an hour to get a phone call back. I have a doc, but he wasn't available. But it took an hour to get a phone call back from VTAC and less than 5 minutes to say, yes, you definitely have shingles. There's not a lot we can do with you now that it's been 60 hours. So I think that there's so many benefits to this if it's not really an emergency.
I mentioned to the chair before the meeting that we are constantly evaluating what we do, and one of the pushbacks I get from that point you raised from emergency physicians is, look, these walk-in sort of issues, these low acuity issues, are not the problem of are not the driver of the overwhelming problem of emergency departments. It's not low acuity that's causing crowding in emerge. And I accept that point, but I also push back on it and say, but since when did we stop valuing the impact on the person? Because if you have to go and sit in that waiting room for 8 hours, sure, that's not going to change the hospital flow. It's not going to change the overall impact of the emergency department, but it absolutely impacts that person. And so if we really want person-centered care, we can't just rely on the crowding issue in emerge and the flow to admissions to hospital and then alternate level care days. We also need to think about the impact on the people as well. So thank you, Councillor, for raising those points as well.
Thank you. Follow-up, Councillor Refrenier.
Yeah, so the photos. So when someone calls VTAC, if they have something that needs to be shown to a physician, when did that start? Because I know that I made a phone call to VTAC a couple of years ago and ended up subsequently, they recommended that I go to Emerge when maybe a photograph could have been taken. So when did that start coming into the process?
2015. We literally started it. I remember, and I say that slightly flippantly, but in 2015 we started in the Arm-Prior Family Health team using the Ocean program, which had this secure sort of message sort of capability. So I make the point that this is not actually new.
No.
Dr. Efflick made that point in 2020, but we've got to move to a digital sort of way of thinking about healthcare. Like these sort of tools did not magically appear in the pandemic. Now, they became enhanced, they became more plentiful, but we still did virtual care. I still made phone calls to my patients from 2007 when I first became a doctor. It's just that we've been more organized now and more focused on how we sort of meld the in-person elements with virtual care elements, with digital technology, with secure messaging.
So it's not new at all?
It's not brand new.
So obviously the physician thought I should go to Emerge for other reasons. So that's fine. Okay, well, good work. Thank you.
Councillor Nicholson, please.
Thank you, Chair. And maybe the question might not be at our guests, but more to our chief. What are there any limitations in terms of us as an upper tier government in terms of supporting this initiative? How are you set up to continue to support growth and continuation of this kind of program?
Thank you, Mr. Chair, and a huge thank you to Dr. Fitzsimon and Judy for presenting the information today. Deputy Chief Grenier, who just stepped out of the room, is the one who has the responsibility internal to our department. So maybe a good refresh in that the transfer payment agreement was between Ontario Health and the County of Renfrew for VTAC in sort of in the way it's been described, and the deeper dive into IVC, which has been explained today. So from there, where we previously had a close working relationship with Arm-Prior Regional Health and Karen Simpson and that group, it was essential from our perspective to bring on another local family health teams, such as Judy's team, to work with Dr. Fitzsimon and all of the physicians to continue to deliver those services. A couple of things have happened this year. It was July 1st when we became the direct recipient of that transfer payment agreement from the province. I don't know if we've actually got our money yet or not, but suffice to say, that's been moving along in the right direction. With that, that's when we also signed a formal agreement with Petawawa Centennial Family Health Team for the IVC program, but I'd say more importantly, to be able to provide a clinical lens and expertise from a family health team's perspective and complementing the work that Dr. Fitzsimon's been doing with us since day one. So all of that being said, I think we have a very strong foundation to the point where other municipalities, other provinces, the federal government and beyond are looking very closely at VTAC as not only a virtual solution, but a layered care option that allows the physicians to work locally with our paramedics, work locally with family health teams, and not be kind of a one and done encounter. In fact, it's far more complex and sophisticated than the services that kind of popped up and went away during the pandemic. When we think about what that represents politically or even operationally, we know that John Yakubuski has been incredibly supportive of this program and has heralded its success based upon the literature that's been published at Queen's Park. And you may recall last winter, John came with the very good news that VTAC has received permanent funding and that VTAC will continue to service the almost 30,000 people who do not have a family doctor in Renfrew County. We can see that with the rise of IVC, as Judy presented, we've been able to try to work away at that waiting list to be able to reduce the numbers. And those are really quite modest gains based upon what I know they're capable of with the physicians that Dr. Fitzsimon has recruited and the back office clinical specialists who can be referred to from those virtual physicians. So I think we have a physician services agreement with the province, which is unique to Renfrew County that I think is working for us right now. There are some problems associated with that are bubbling up. Namely, some physicians have taken exception to the fact that if you are attached to a family physician in Renfrew County and you choose to use VTAC for whatever your reasons are, that physician may be penalized for the fact that you've stepped out of their practice to receive services from another physician. So there is some grumbling, and rightly so, that has a potential negative impact on the relationship between that patient and their named family physician. However, we did it through the negotiations process, raise this with government as a potential problem, and there was no movement on the point that if you have a named physician and they're being paid to have you as part of their service, that if you're reaching around them to another like service, that there's a potential negative billing associated with that. So Dr. Fitzsimon has been working with the physicians to say, here's what that potential monetary consequence is, but we know the vast majority of negative billing occurred with physicians who have now since retired and had very little capacity to be able to serve their patients in a timely way. We know the physicians in the county are doing an exceptional job of managing the patients that they have within their service and have an obligation to provide availability to those patients so they could provide like services to VTAC in terms of the timeliness of access to care. But we also know that the almost 30,000 people without a family doc only have the choice of calling 911 or going to the Emerge. And now VTAC and IVC represent some alternate pathways that are good for the paramedic service, good for the hospitals and the emergency departments, but most importantly, good for our communities and provide a new safety net that didn't previously exist. So what can we do? We need to remind the province that they've provided us permanent funding and make sure that we don't have any slippage at year end around their commitments. We need to make sure that they understand the true impact. So there are evaluations going on with Dr. Fitzsimon and his team from the MOLFOR. That is continuing to build evidence towards the value, the economy, and the impact of the programs. So we need to continue that work. That's already 100% funded through VTAC. And the province has also asked us to set aside $100,000 for them to do an independent evaluation of VTAC. So we'll see what those results look like and whether there's any political jaundice to that or whether it actually shows the impact to the people. And remembering that the responsibility for recruiting physicians seems to have become everyone's responsibility other than the province. And despite best efforts by many, we're getting onesies and twosies for physician recruitment. We've heard from Dr. Fitzsimon today that we have 17 physicians that have all agreed to help us with the challenge. And the challenge is, how do we attach people that want to be attached through an IVC or integrated virtual care model? How do we continue to service people for episodic primary care, but knowing that it's layered with the paramedics, with other primary care partners within the system? So we need to keep the pressure on the province to say, don't forget about the program. And as capacity builds through Dr. Fitzsimon, Judy, and Matthew's work, we need to be able to find elasticity in those funding models. So if we need more docs, we want to pay more docs using the agreement we have. If we need more physicians with IVC, or even funding to be able to onboard more patients for the physicians we have, we shouldn't be robbing from Peter to pay Paul, from VTAC for IVC for physician salaries. We should be able to dedicate that to bring those patients in, organize their care so that the physician can have clear line of sight as to how to best care for them. I hope that answers your question.
Thank you. Councillor Purcell.
Thank you, Chair. Just a quick question in regards to, I mean, there's so many moving pieces in regards to hybrid care. In terms of medical information, I know that the OCEAN program, you can book appointments online, those kinds of things. I'm just kind of concerned in regards to, you know, the siloed approach in terms of medical information. You know, we have various different providers using Epic. We have different providers that are looking at other different solutions, and it seems like none of them kind of talk to each other. And I think a really, really important part in terms of, you know, maintaining your health and understanding and being part of that that solution in terms of what works best for you is to be informed and to have the information available. Maybe you can comment in terms of how the medical documentation, the medical information is captured, and also the sharing of that information. I know many times I use a specialist and I'll go to referral in terms of Ottawa, and my records don't seem to get there. And thankfully, you know, I can pull up my Epic and say, here is my medical history, here's my information, these are my meds, these are my last, you know, concerns in regards to my medical history. And in some cases, you know, that allows me to proceed with getting treatment or care. In other cases, what happens is you referred back to your referring GP, which is, to me, is just a total waste of dollars and time for that process. So maybe if you could just kind of elaborate in terms of that interconnectivity, in terms of having that information available to the patient as well as the physician. So thank you.
Just before I invite Dr. Fitzsimon to answer, I will bring up, he informed me that he would be late, the warden, but he is given to advising this chamber often that he has a single health card, the green one, and he has lost track now of the number of hospital cards that he has generated, given that he is traveling across the province frequently. And at each of those institutions, they generate a different blue card for him, and yet he has a green card that is with him all of the time. So I think that this is perhaps a larger systemic issue, but I would invite you, Dr. Fitzsimon, at as best you can to satisfy Councillor Purcell's question.
See, Joe, I was thinking of the phrase above my pay grade when you were asking that question. I was at the Trillium conference a few weeks ago where Dr. Jane Philpott was talking. Trillium is Ontario's primary care sort of research and academic conference. Like, this is it's a Canadian level problem, but it's certainly a provincial level problem. There is huge frustration at, look, would we have started 15 years ago, 20 years ago, with developing electronic medical records the way the province did, with dozens and dozens of different providers? Hindsight's a wonderful thing. No, of course, we shouldn't have done that. But we are where we are, and it's a massive, complex, digital, expensive problem to solve. But if I bring it back to the local issue, look, VTAC has one electronic medical record. So anyone that has a contact point with VTAC, their records, their encounter note, their results from any tests are maintained on VTAC's electronic medical record. Ocean is an add-on application which allows secure messaging, like those digital photographs, to flow to and from the patient to the record. So Ocean isn't a record; it's a means to allow information to be shared securely and to have some add-ons like reminders and things like that. The Integrated Virtual Care Program uses the electronic medical record of the clinic it's based at. So if, for example, a patient calls VTAC who already has a family doctor, the copy of that encounter note at the end of that day will be sent to their regular primary care provider. It won't be digital, it won't be automatically embedded in their own digital record, but a copy of the note will go to their provider. 80% of the time they don't have a regular primary care provider, so it just stays with VTAC. If they become attached, they find a local doctor, or they're brought on board with IVC, then all of VTAC's record could move to their new primary care provider. And from time to time, when people ask for notes that are generated through VTAC, maybe they've had some tests and investigations done through VTAC, then we have a mechanism to provide them with a copy of their records. Like, is there an automatic sort of plug-in to access your entire primary care record? That does not exist in Canada. It certainly doesn't exist within VTAC.
Thank you. I would just remind Dr. Fitzsimon that there was a thing one time called eHealth Ontario, but it was not high achieving. That did predate electronic medical records. Any further question or comment, committee? I thank you once again, Ms. Hill, Dr. Fitzsimon. I think that Stephen Covey is the generator of quotes for all purposes. And to achieve goals you've never achieved before, you need to start doing things you've never done before. And I think that both VTAC and IVC are those things. I think that there was a confluence of many things, that these had been certainly conceived, if not put into action, and then we were confronted with COVID, and the pandemic and the aftermath of COVID brought a lot of focus. There were a lot of things we found out that we couldn't do. When COVID came along, it turned out that we could do them. And I think particularly in reference to your comments, Doctor, vis-a-vis it's not doing this, it's not designed to do that, and also what VTAC is doing, which is the episodic and responding to urgent but not emergent needs, is a very valuable in our community. Again, that the specter of 30,000 unattached, when we're hearing that the province may get to 25%, we passed that mark some time ago. And yet it is not what is often referred to as the wraparound, that is the teams-based approach, that is we need to be embracing the teams approach. But ultimately what IVC, having grown out of that is the goal. Is that wraparound that is available to our community, and particularly the challenges that we have here, given the low density of our population. We are scattered over the largest county in Ontario. The enormity of those challenges, this is what digital is going to provide to us. And I often think even of eHealth that I had mentioned earlier. I think we probably all remember the toddlers that took to iPads like it was water, like fish to water. And in another 10 years, we'll look back and think, boy, were you folks simple. What was wrong with you that you couldn't develop these approaches? And I think that has been one of the barriers in response to one of the questions, what are the barriers? I think one of the barriers is that it is outside of our understanding of what family medicine is, but I think we're really only keeping pace with where our society is going right now. And in fact are probably even behind the times. So I applaud all of these efforts. Thank you once again for being here. I would like to invite, in the absence of the warden, certainly Mr. Kelly, Chief Nolan. I think it's appropriate to celebrate just bear with me, I brought up the the Bright Lights Award. And I would like to if we could, get a photograph, a picture, to celebrate the integrated virtual care through the Centennial Health Team. Love to be able to celebrate that with you. With that, then we're going to go back into our agenda report. With that, first item for reporting is emergency services. The floor, Chief Nolan, is yours.
Great, thank you, Mr. Chair, and to members of council. The first item for today's report is related to VTAC, and I think that we've spent an appropriate amount of time being able to hear from our partners in the program, but also be able to better understand. And I go back to Councillor Nicholson's ask that he'd like some more numbers and some more updates. So there you go, sir, on that element of the program. And there'll be more good news stories and deeper dive into different elements of our program in the new year. So item number one, Mr. Chair, really I think covers off what we wanted to hear about today. Related to VTAC. The Bright Lights Award is an incredible achievement, and I think it's probably also important to note that the Bright Lights Award awarded by the Association of Family Health Teams of Ontario and for a population-based approach to community achievement. So when you think about what that means, it means that the other parts of the primary care and family health teams are not only acknowledging but celebrating the work of VTAC. And I think, the natural reaction within the health system and with government is often to feel threatened by change and to reject change and find reasons why it's not possible. This award, I think, really shows the advancement not only of VTAC but also a greater understanding of the importance of these programs. So a big thank you to the Association of Family Health Teams of Ontario for recognizing the work that the county and its partners, predominantly Petawawa Centennial Family Health Team, are doing in this space. Item number two is a letter from the Honourable Jill Dunlop, Minister of Colleges and Universities, regarding the Ontario Paramedic Service eligibility for the Ontario Stay and Learn Grant, or Learn and Stay Grant, Mr. Chair, and that letter is attached for people's reading. Item number three is related to improving community resilience, and you may recall at the last Health Committee meeting, Councillor Nicholson walked us, at the last emergency management meeting, of which some of Health participated, we did a case study, and that case study was pertaining to flooding and flood mitigation efforts, and one of the recommendations that was being shared within that experience was that we need greater capacity around flood mitigation as well as sandbagging efforts. So with the emergency management grant that's coming out, myself, Steve Ospenko, who's my alternate CEMC, Lee Perkins from Public Works and others are now collaborating on an application. It's a modest application up to $50,000, but that would certainly give us some capacity to purchase a sandbagging machine to be shared amongst all municipalities. And with that, also some funds to be able to provide the training, and I'd say more importantly, the coordination of volunteers to be able to assist in flood mitigation activities. That's not dissimilar to what the THW has done in Germany around how do we train volunteers, inspire volunteers, motivate volunteers within the local municipalities, and then how do we encourage those teams of local municipal volunteers to be able to assist in other municipalities who are under duress as a result of an emergency in their area. We think of flooding, but we can also think of windstorms, tornadoes, ice storms, you name it. In our lifetime, we've had quite the potpourri of experiences. But I think given the frequency and impact associated with flooding, that was our focus for the equipment. However, the net benefit of organizing and training and engaging volunteers from local municipalities centrally so that we can support these efforts at the county, it provides us additional opportunity to be able to hopefully create a Renfrew County version of a civil defense volunteer group that have trained volunteer leaders who could then work with walk-up volunteers, NGOs, and other organizations that want to assist going forward. So we have had discussion about this since 2015, 16, 17, and then the major flooding occurred, and we had some level of readiness thanks to the THW, the German Civil Defense Group, who came over and provided us some advice, guidance, and training. This grant will give us some of the tools that we've talked about for many years. I understand the City of Pembroke may also be applying for a sandbagging machine. And I think you can't have too many within the municipality, given that the county's unit could be shared amongst all municipalities. So we can look at how we rally around that. I had some quick numbers, and we were nearing 500,000 sandbags deployed 2017, 2019. So those are very significant numbers when you think about every one of them had to be filled by hand. So what would a machine like this be able to do? It would give us thousands of sandbags a day per unit, but even that is really a drop of sand in the bucket when it comes to as far as this effort. So we're going to be moving that forward, and I just want to bring that to committee's attention because the deadline is November 30th, so this is going to move forward. I'll bring the final product to you, but it will likely be after the deadline date, so just know that we'll be putting that in. And we certainly welcome the City of Pembroke and any other municipalities that are putting grants in to collaborate in the same fashion of how do we engage volunteers, how do we share the tools, equipment, and know-how that we have so that if something were to happen in one municipality, that we already have a team that's interoperable and can move in to help lead volunteers in another municipality. I think that needs to be one of our goals going forward. Item number 4 is the Treasurer's Report, Mr. Chair, and I'm not sure how you would like to address that.
I think since this is the last of the information items, we'll pause there. We'll go back through the information items. I would invite questions, comments on any of those 4 items, which would be inclusive of the Treasurer's Report. Perhaps as we get back to 4, if there's anything in particular you would wish to draw committee's attention to, that will be the opportunity.
Okay, at that time.
All right, thank you. With that then, committee, going back to page 5 of your reports, any further question or comment on RCVTAC update? Item 2, the Minister of Colleges and Universities regarding the Learn and Stay grant. Item 3, the Improving Community Resilience. Councillor Lafreniere, then Councillor Nicholson.
So thank you. I've always got a lot of confidence in anything that you're behind, including this grant, because you're very eloquent in the way that you explain everything in detail. What I'm wondering is, is Chief Sell working with you on this? I know that you have a group for emergency preparedness, but I'm wondering if you've shared this grant information with Chief Sell, because I imagine he'd be the one. He is heading up our emergency preparedness committee, I believe, now for the city. Have you worked with him on this?
Thank you, Mr. Chair. So indirectly, Steve Ospenko, who's my CEMC alternate, works very closely because he's also the regional coordinator for all the CEMCs in Eastern Ontario. So I know he has been working very closely with Chief Sell.
Okay.
I happened to find out about Pembroke's interest in purchasing a sandbagging machine from a vendor, actually, because he saw my address for the county office here and said, "Oh, you're already buying one." And I said, "Oh, is that right? Let's talk about that."
Okay.
So that's how that came to my attention. My approach with this one with Commander Ospenko is that once we have our draft application in, we're going to share it with all the CEMCs in the region.
Great.
So that others can do the same back.
Okay.
And the timelines for this grant application are relatively short from a provincial lifespan perspective. So I think it's best that we all move forward based upon the individual municipalities' interests, but recognizing with the 17 municipal local governments, some have the capacity to put an application in, some don't. And I think that really we're taking a clearinghouse approach of let's put something in. We're going to name the 17 municipalities of the County of Renfrew and say that this will be a resource to them. In fact, the county's need for sandbagging, save and accept some construction and long-term care homes is actually very little. We're simply trying to take a facilitative approach, servant leadership approach to helping your municipalities when the time comes.
Exactly, and your leadership is always welcome in any project. Further to that, in terms of the rescue boat, I know that we're purchasing a new boat, and it came up in conversation around City Council that the county now has one as well. Those could be looked at as shared commodities for our municipalities. And I guess what we were wondering was, is there a boundary where established where Pembroke would respond to a water rescue or the county would with their equipment? Can you elaborate on that, or is that part of your scope?
Chief? Yep. Sure, thank you, Mr. Chair. So, yes, we
sharing resources.
Yes, we purchased a watercraft this past summer, post the fires in Greater Madawaska, where there was a water access requirement to be able to access the fireground, and as well the downing of the Chinook aircraft, and working with the dive teams, as well as many other medical and traumatic calls that we've experienced, not only this year, but in years past. So we purchased a boat actually from Cornwall Fire, who had a purpose-built boat for removing individuals from the St. Lawrence. Different than many fire service approaches where, and I think this is the distinction that I'd like to make for you, is that to me it's not a jurisdictional boundary in terms of the who goes where. It's a jurisdictional boundary in terms of what are the services that we intend to provide as agencies. So it would be no different in my mind than if there was a motor vehicle collision on the highway, to say, oh, well, fire's going to that, there's no need for police to go or paramedics to go or vice versa in any way of that. You triangulate that. Really, the conversation should be about what are the reasons that individual agencies might respond to something, regardless of the jurisdictional boundary. So unlike fire services, we don't have mutual aid agreements. We take care of everybody within the county, no matter where you are, what your need is, provided there's a medical element associated with that. So much like the Sierra team's mandate, it's about bringing care to the patient, not bringing the patient to care. And the paramedics, given their prima facie of mandated responsibility of providing the highest level of care in the shortest amount of time, regardless of the circumstances you find yourself in. So I'll give you a look at this in a different way for you, or a different lens. If there's a motorboat broken down on the river, or if there's a motorboat on fire on the river, and it doesn't implicate humans and their care, we have no interest in providing any support to that, unless it's actually the firefighters that we're there to provide support to, because there may be strenuous activity, there may be other hazards, there may be a require for safety officer as part of the process, or we require additional supports. In the case of the Chinook, obviously there were many watercraft, there was lots of things going on, but we had paramedics embedded with the dive team in the middle of the river, given the depths that were being experienced and the numerous medical conditions that the divers were experiencing when they got back to the surface. So that's our lens. I understand that fire services have different types of agreements and jurisdictional boundaries. We do not. So if said differently, if there's a marine call that involves a person, we will be there for the person. Police may be there for investigative purposes. They may be there for recovery. The fire service may choose to respond for whatever the local municipality asks them to respond to. But if it's medical, if it's traumatic, we'll be there under our own steam for our own purpose. And our commitment is to work collaboratively with any other agency or bystander who can improve the circumstances for the individual that we're responding to.
Seemed to some that we strayed off, but with me it's about what collaboration exists between, you know, your service and the city services. So thank you.
Yeah, thank you. And if you have a boat for sale, let me know.
Councillor Nicholson.
Thank you, Chair. And I just wanted to thank the Chief again. This is an area where I think, like you said, servant leadership on behalf of the municipalities is an excellent way to have such a valuable resource in one location. I really want to emphasize the potential template for the civil defense volunteer group. That is a key resource and a way that we can pool our efforts to not only address an emergency in one municipality, but even if that means going and helping somewhere outside of the county. I think it's a great initiative. I think this is a great way to launch it, using this as the impetus. And I look forward to seeing how that works. Thank you.
Thank you.
Thank you. Councillor Murphy, please.
Thank you, Chair. Through you to the Chief. This wasn't a typo, right? You did mean 5 million, not 50 million, because 5 million is not going to ensure communities across the province have resources and equipment. I just feel like with the amount of municipalities we have and the cost of some of the necessary equipment, not to mention resources, I feel like this is a very, very, very small fund for grant applications. And I say the 50 tongue-in-cheek. Do you happen to know why it's only 5 million when we know that this is such an important fund?
Chief? I think there's 3 parts. No, it's not a typo. Well, I've been accused of lots of things, and typos is sometimes one of them. So my apologies to Craig for that. But from a fund perspective, you may recall the Joint Emergency Preparedness Program that the federal government did away with late in the 2000s, early teens, I think it was, and that really was a fund that municipalities could tap into for effectively what this is calling it. But I absolutely agree, $5 million and a $50,000 cap per municipality is a drop of sand in a bucket, quite literally. However, being responsible in the way that we're trying to organize the program, we're going to make this application. We're going to do a lot of things with a little bit of money, as we're very good at doing. But I think, like you saw with VTAC and like you've seen in our other program areas, we will demonstrate a greater need. We will demonstrate responsibility in the way that we organize and distribute the program. And I hope that that will then serve it up for you at AMO or Roma or wherever we go to say, thanks for the little bit, and let's just call that an acknowledgement. But we actually need some real funds because, as our councillor from Whitewater has experienced disaster relief funding on 2 occasions within the municipality, this is really the first signal of any mitigation or acknowledgement that we can do better than simply waiting for the claims to flow in and the town halls to fill up. And that's why we've been consistent in that, but I can't make an apology for the amount here, unfortunately. We're just going to see if we can get 50,000, and let's try and get as many 50,000s as we can amongst the municipalities so that we can all put it in the pot and find smarter ways of working together without jurisdictional boundaries, without turf, and know that we can be there for one another in a way better than we have in the past.
Good answer.
Thank you. Anything further? I just wanted to pick up on Councillor Nicholson's comments. Certainly the sand magging machine would be very welcome. We experienced 2 traumatic flooding episodes in 17 and 19. But from my perspective, even more perhaps important is the second component of the essentially the civil defense. I certainly stand to be corrected. I'm not sure. So Bill Blair was our past Minister of Emergency Preparedness, and I think it was Bill Blair that had actually just been kind of off the cuff surmising that that might be a direction that we should be going in Canada with respect to our response to emergencies, and I could not agree more. As we've discussed in this chamber, probably in 17 and 19, in times of need in our communities, those that typically have volunteered to step forward into our response committees are themselves subject to the same emergencies that they are intended to be responding to, and it is such a challenge that I think that this is perhaps transformational, and I really appreciate the concept of this, and I think that once again, proof of concept may be done within our community, that from there can be the springboard to scale up on a provincial or even national level, and I'm certainly very appreciative of that component. There's no question episodically the sandbagging machine will be very useful, but I think the second component to this is the one that has real legs attached to it. Moving on then, as I'd indicated, anything that you wish to draw attention to in particular on the Treasurer's report, Chief?
Thank you, Mr. Chair. So when we turn to the budget page 10, there's a couple of areas to highlight in this regard. So certainly in the paramedic salaries, when we're looking at where we're at in year-to-date budget and actuals, the operating paramedic salaries are trending higher than the anticipated budget for this time in the year. But then I would draw your eye down about a third of the way down to revenue other, where you see $404,000 of revenue, about $300,000, and so above the anticipated amount. So that line item represents, in small part, revenue from the union for the time that they take off and have to repay us, but in large part, Mr. Chair, and thank you for some questions in detail regarding these line items, that represents a new revenue related to paramedics working in the emergency departments, not the offload funding that we've recently received, which would be an additional unanticipated revenue of $400,000. This represents our partnership with the Armpire Hospital and Pembroke Hospital for an unanticipated revenue, given the mid-year contract that committee and council will remember signing. But then secondly, remembering that that's also driving up the paramedic salaries above in terms of where we're at for the year, because we have a new offsetting revenue, and of course we have a new expenditure that's 100% funded by that external agency or those external agencies. So I think that's important clarification, Mr. Chair. As well, when we look at our legal expenses for the year, we had a significantly lengthy discussion with our partners in labor at the union going into the last collective agreement. Many of those legal costs have rolled into this year's budget to pay for that. And as a reminder, we are going back into bargaining with CUPE next month, actually, and this time we'll be working directly with our Human Resources Department and then using legal in a different and hopefully less way. And I hope that we have a less of a contentious bargaining experience going into this year, but those are the expenses associated with that, as well as other ongoing legal expenses that we experience within the service. And then when we look at the balance of the budget, Mr. Chair, certainly revenue, special projects, we have offload funding that's going to be coming to the county that's not yet represented here. Mr. Burke, you can correct me if I'm wrong in that, but since that hasn't been signed off, it's not showing up, nor have we drawn down any expenses because the transfer payment agreement is just being signed now. And apart from that, Mr. Chair, the emergency management budget is pretty status quo at this point. Of note, the town of Renfrew, through the media, we were notified that they are reducing their fire services use of the Central Ambulance Communication Center on contract to us. So that disbursement of costs associated with that service will likely be shared with the remaining fire services within that agreement for next year. So you can expect some changes to that, Mr. Chair. Other than that, I think the rest of it's fairly self-explanatory, but happy to answer any questions.
Okay, thank you very much. Chief, invite any questions. Councillor Nicholson.
Thank you, Chair. And just so I can appreciate, in the paramedic other category, in the middle of the page, there's just a couple of variances, and I apologize if it was already mentioned and I just missed it. But when I look at the variances for long-term care expenses and VTAC expenses, there's a very large variance. Is that just an accounting error, or is something that changed in what we had forecasted versus what was being delivered?
Thank you, Mr. Chair. So there's a reconciliation underway right now between Deputy Chief Grenier and Finance in terms of where community paramedic time was spent. So as you may recall, 2 of the community paramedic positions we have are 50-50 funded. They've all been pointed at the community paramedic program to date, which falsely inflates that line item where really it should be back. So we're going through the reconciliation process right now to be able to repoint those funds, which is normal at this time of year when things start to grow and you start to see what's landing where within the budget. And then as well, we have had variations in terms of the revenues associated with those programs. So it was only July 1st that we took over all of the VTAC related funding as a transfer payment from the province. Prior to that, we were a contract service to our Empire Regional Health. So we've taken on increased expenses, but we're expecting matching increased revenues associated with that program because it's all now coming to us. And one small example might be, for example, the Grove, where we used to use it as one of our assessment centers in Arnprior. That's now, with the assistance of Mr. Davis, at McGonigal. We paid for all of McGonigal last year through our budget, but the county has realized revenues from both Arnprior Regional Health for a portion of the space, as well as VTAC is now direct funding the remainder of that space. So those are some variations that will occur within the assumption of VTAC. And from a staffing perspective, I anticipate that leveling out quite close between operations and community programs, in part showing up within CPLTC and in the VTAC line items.
Thank you, Chief. Any further questions or comments? I appreciate you speaking to, I had my own approach to this or any of the Treasurer's reports. Things that are concerning are highlighted in red, and things that are enlightening are in green. So certainly on the other revenues, very pleased that there are substantial funds flowing on both the other budgeted for the year at 125, but already over 400,000, and likewise special project was budgeted at $50,000 and is already at over 375. So those are certainly offsetting a substantial number of the costs that we're seeing up above. The one-time COVID funding, because I know that this also is repeated in Mr. Blackmore's Treasurer's reports, is that still ongoing dedicated funding, or is this part of the, is that Safe Restart, I think was COVID funding that had been provided to us but that have not been fully utilized? I'm assuming if it's one-time funding, it's new. Otherwise, it would likely be a transfer from reserve. Can you speak to that, Chief?
Maybe perhaps I'd invite Mr. Burke to speak to that.
Mr. Burke, please.
Thank you, Chief Nolan, and good morning, committee. That is one-time funding that ended in March, but it was not part of the Safe Restart grant. It was a separate provincial funding for COVID expenses specific to paramedic services. That is now complete.
Okay, thank you. So it's very welcome. We had budgeted $0 and we received just under $125,000. So very thankful for that funding stream. Chief, yeah.
Happy to further elaborate just for context. So, and thank you, Mr. Burke. So you may recall at the end of the province's fiscal, they coughed out a bunch of COVID funding. And we hadn't anticipated or expected money beyond December 31st, but in fact they came out, I think it was in late March, and said, and here's your money, based upon a bunch of retroactive reconciliations that we'd been doing. So I think it's clear, as Mr. Burke denotes, that's likely the last of that, but that there are other Safe Start funds and other things that may have some legacy application. But at this point, that's going to real cost, part of which within VTAC and CPLTC, but also within our regular operations. So it goes, when you look at our total variance to date of 82,000, it's putting us certainly in the ballpark of what our anticipated costs were for the year, despite the fact I've reported on numerous occasions the pressures associated with overtime and meal breaks and all of the ongoing issues from a staffing perspective that we're very sensitive to, and trying to get our staff off on time and get them their meals and so on and so on. But there are true costs associated with that are in many respects outside of our control.
Okay, thank you. The final question, and this I will throw it to you, Chief, but it probably is going to be more in the bailiwick of Mr. Burke. Just on the very top line, typically at each quarter when we are reviewing the Treasurer's report, I approach it from the perspective at Q1 we have 25% of the year passed, Q2 is 50, and Q3 is 75. So typically that's what I kind of base my own analysis on how we are proceeding through the year. And I just note the YTD budget for the paramedic service is in fact only 70% of the full year. I'm wondering, is there a weighting that kind of is applied throughout the year? Are we typically back-end loaded, i.e. does the third quarter typically experience an overweighting of the activity, financial activity?
So through you, Mr. Chair, maybe I'll answer the first part, and then I think Mr. Burke can speak to the methodology behind it. In years past, we had done a rationalization exercise that, for example, vehicles, which typically are purchased in the fourth quarter of the year because it takes almost the full year from the time you place the order to come to fruition. So we would show that as a fourth quarter pressure only and not show it in the first, second, and third pressures. I'm not sure whether that methodology is holding true, but typically the fourth quarter is a bit of a hurry up and spend period because it's taken so long to get things. By the time the budget is approved and the orders are put in, we end up having a push, a rush. It wasn't uncommon for Deputy Chief Leahy to drive to Montreal between Christmas and New Year's to pick up ambulances so we could have them, get plates on them, and be able to expense them within that year. That's just been our experience, but maybe Mr. Burke's better to speak to the methodology.
Mr. Burke, please.
Yes, and through you, Chair. So the year-to-date budget is allocated by month, and where we know that we will likely have a difference, we will budget that way. Like, for example, insurance, we would pay that once a year in January, so we would budget the entire amount up front. Where we don't know or don't have a good reason to assume that the budget wouldn't be evenly split, we will evenly split it across 12 months. In this case, the biggest factor weighting into the final quarter is the transfer into the paramedic equipment reserves, which we would typically only do about once a year on an annual basis, and it would be done December 31st. So that's why the back end of the year looks heavy.
Okay, thank you. And I actually appreciate and am much in favor of that approach. I can't remember how many years ago in a discussion on a Treasurer's report of the day, that was ultimately what I was suggesting. Once we have developed a pattern and we know that it is unequal distribution across the year, then we can begin to bring some more sophistication into the financial reporting. So thank you, Mr. Burke, for that. If there's nothing further, then, Chief, I will go back to the report on page 6, committee, and if you could take us through resolutions, please.
Thank you, Mr. Chair. And would you like me to do these one at a time? Item number 5, resolution related to dedicated offload program. That committee recommended County Council that a bylaw be adopted authorizing the warden and CAO to sign a memorandum of agreement with the Ministry of Health for $421,000 one-time funding for the 2023-2024 funding year to support the dedicated offload nurse program. Background, Mr. Chair?
I just seek a mover, please, for that. Councillor Grills, seconded by Councillor Weir. Background, please, Chief.
The background being that a notification of funding was received by the Deputy Premier Minister of Health, Honourable Sylvia Jones, in the amount of $421,000 for the dedicated offload program, was brought to committee in September, attached as Appendix ES3 for the MOA and proposed budget. If I may make a few comments about that, Mr. Chair.
Please do.
Just to extrapolate on that, I'd like to acknowledge the work of Deputy Chief Grenier in this. It's no small task to work with our union, the unions of the hospitals, to be able to find ways of innovatively staffing these programs, and to be able to do that in a reasonable amount of time, to be able to effectively change the way that we're doing business, to encourage better flow within the hospital, but also create a new cultural norm of paramedics working in the hospitals, shoulder to shoulder with the nurses, physicians, and allied health, to be able to facilitate the offload of the paramedic patients, but also to be a capacity multiplier within the department itself. So a big thank you to Matthew for that exceptional work. Recognizing that this came out late summer, it's taken a while for us to be able to establish the agreements, which we now have with our partners, certainly at Pembroke Regional Hospital. Renfrew Hospital, we're still in discussions with, who are also eligible for a portion of this funding. But it is our goal that by March 31st, we will expend this money and improve the level of service so as to reduce some of the pressures within the health system. Although it says one-time funding, I'd just like to let you know that this program has been in place for over a decade on one-time funding. And it's only this year, with the insistence of the Ontario Association of Paramedic Chiefs, that we are able to expand this program beyond large urban hospitals to now include other hospitals with eligibility based upon their patient flow, acuity, their volume, and some of the stressors that are within the health system. So we're happy to have applied on behalf of Pembroke and Renfrew hospitals, and also to be a part of the solution by creating opportunities for paramedics to work in that capacity within those facilities. Mr. Chair.
Thank you, Chief. You had anticipated my question. Of course, this does, it is not for the, 6 odd weeks that are left in 2023. This does extend to March 31st. And I had a question on whether we had anticipated full utilization. Very pleased that we are going to be able to take advantage of that. Any further questions, comments on the offload nurses resolution? Seeing none, all in favor? That is carried. Thank you. Moving on then to item 6, please, Chief.
A recommendation that Health Committee recommend the County Council a bylaw be adopted authorizing the Warden, CAO Clerk to sign a memorandum of agreement with the Pembroke Regional Hospital for advanced care paramedics to participate in emergency department to facilitate early offload transfer of patients onto hospital stretchers. Mr. Chair.
Thank you. Once again, I would seek a mover and seconder. Councillor Purcell, seconded by Councillor Murphy. Background, please, Chief.
Attached to this document is a memorandum of agreement between the County of Renfrew and Pembroke Hospital for advanced care paramedics to participate in the emergency department as a team member to facilitate early ambulance offload transfers of patients onto hospital stretchers and to provide clinical care and management to increase patient flow in the emergency department. Further background, if I could.
Please, yep.
Just for further context related to the background, this obviously is directly related to number 5, but in addition to the conversations with the unions, we've also been working with our own Human Resources Department to establish this agreement with the hospital. So this is actually a fairly complex piece of business that it's really great that the province has given us $421,000. It's incredible that based upon the relationships between the paramedic service and the hospitals that we've been able to facilitate this level of change, both at a cultural level, but also organizationally between these memorandums of agreement. So again, a big thank you to Matthew for quietly making that happen in the background so that we can actually do something with the money and do something meaningful around patient flow.
Thank you very much. Chops to the Deputy Chief. Questions, comments on the offload staffing? Seeing none, all in favor? That is carried. Thank you. And I believe finally, item 7, Chief.
that the Health Committee recommend a County Council of bylaw be adopted authorizing the Warden CEO clerk to sign a memorandum of agreement with the Renfrew County District Health Unit to contract the community paramedic program to deliver and or assist with the delivery of influenza and COVID-19 vaccinations for the term of October 30th, 23 to December 21, 2023. Mr. Chair.
Thank you. Once again, Councillor...
December 31? 31.
Oh, December 31. Yeah, just correct that in your score sheets. Moved by Councillor Purcell, seconded by Councillor Grills. Background, please, Chief.
Thank you, Mr. Chair. So in addition to what's written here in terms of the background for the delivery of the COVID-19 influenza vaccinations, the term of the agreement, as correctly stated here within the document, allows for reconciliation of costs associated with the paramedic involvement. As you may recall, the province funded the paramedics for COVID-19 vaccination through previous COVID funds. We've been able to establish an excellent working relationship with our partner organizations in that regard. However, there was no longer funding associated with the paramedic involvement. So as to keep it straight and keep it clean, this agreement sets out a rate for reconciliation, inclusive of a benefit cost for the paramedics for both the training and the services being carried out by the paramedics. So once again, we're always happy to help, but we also need to be able to represent the interests of the county. And again, the last bouquet here for Deputy Chief Grenier, who had a terrible start to his day striking a deer on Highway 17, is that he's been able to establish never before contract with public health for us to be able to work to make sure that the residents, especially those that are shut-ins and those within the county that would not otherwise be able to access vaccinations, are able to do so in full cost recovery in partnership between the health unit and the County Renfrew Paramedic Service. Thank you, Mr. Chair.
Thank you, Chief. Once again, committee, any questions, comments? Councillor Nicholson.
Thank you, Chair. And it's interesting to see that number, and I applaud the process. Is that a number we've generated internally using our own figures?
That's right.
Is there anything available provincially with those types of rates as a comparator across paramedic organizations?
Chief, please.
The numbers through you, Mr. Chair, are as variable as the collective agreements themselves across the province. So this reflects our cost recovery. This is not a money-making effort. This is simply how do we recoup some costs to be able to do something that is as meaningful as vaccination and is as impactful as that harm reduction prevention approach.
Thank you. Any further question or comment? Seeing none, all in favor? That is carried, and congratulations, Chief Grenier. I understand that you hunt with a 4-cylinder Subaru. It's unorthodox, yet successful just the same. With that, I would now seek a resolution to accept the emergency services report, please. Councillor Lafreniere, seconded by Councillor Weir. A final opportunity for questions on any item before us. Seeing none, all in favor? That is carried. Thank you. It is 10:58. We are going to take a brief recess until 11:10 a.m. sharp, at which point we will come back to order, and I will twiddle my thumbs if we do not have quorum live. We are back in order. Welcome the committee back. And we are going to go directly into the long-term care report, which can be found beginning on page 56 of your agenda reports. Mr. Blackmore, please.
Thank you, Chair Donahue. Good morning to all, and through you to committee. Your report begins on page 56. The first two items are detailed bed vacancies for each of the county homes for the periods August to October 2023, demonstrating that both homes continue to maintain the minimum 97%, exceed actually the 97% occupancy required to obtain 100% of funding. Item number 3 gives an account of the wait list for the Renfrew County long-term care homes. We can see at present there are 685 applicants presently awaiting placement, and 685 awaiting placement from community and hospitals. There are also 78 residents residing in long-term care that have identified one of the county of Renfrew homes as their first choice, and this represents 415 out of 886 that have indicated a county of Renfrew home as their first choice. Item number 4 summarizes the most recent COVID-19 guidance document update for the province of Ontario, specific to long-term care. And what that's about essentially is, as of November 7th, all long-term care homes were to require staff, volunteers, students, to wear masks while in the home. It was strongly recommended by the Chief Medical Officer of Health that visitors also wear masks. Effective the Friday that the notice came out, just prior to November 7th, both County of Renfrew homes implemented the masking policy as was mandated, in addition to following the recommendation of the Chief Medical Officer of Health requiring family and all visitors to wear masks also. And just a quick survey around Eastern Ontario long-term care homes, County of Renfrew homes, that the majority have seemed to have taken this position insofar as requiring visitors and family to wear masks as well. Item number 5 is the Treasurer's Report as of September 2023. It starts on page 59 of your report. And as you can identify, there are several budget lines that continue to show us a significant variance, largely related to COVID expenses and funding. And that particular fund, as Daniel alluded to earlier in the Emergency Service Report, specific to long-term care, ceased March 31. However, there are still items listed throughout the budget that offset some of the expenses we've incurred. And by way of example, on the general administrative lines on page 61 of the Manor and 68 of the Lodge, you can see that both lines are over, but that's in large part due to the screeners that we had on staff that were paid through that COVID funding. So when you back out the expenses from the revenue received in COVID other, that line would actually show a negative variance, sorry, a positive variance rather. And as indicated last Treasury Report review, you'll note that there are significant underages in direct care staffing, in large part due to the money floated to us from the ministry for supplemental funding, supplemental direct care funding, and our challenges at present to recruit to fill those positions. Item number 6 is our Accreditation Canada survey award. Very pleased to announce that both County of Renfrew long-term care homes, Bon Chemin Manor and Miramichi Lodge, have achieved the very highest rating awarded by Accreditation Canada, accredited with exemplary standing. No small feat in that certainly both homes have enjoyed that rating previous, but this is our first attempt at a joint accreditation rating. So a very special thank you to all of our stakeholders that participated throughout both Renfrew, throughout the county. Certainly our families, residents, the elected, most certainly Chair Donahue, the Ward Nemo, and CAO Kelly for their participation in the accreditation survey itself. And without question, staff that are, largely responsible for the exemplary care that we do provide. If not for them, we would not have received this award. So just a special thank you to the staff and all that they do to deliver the best possible care in what have been some very challenging circumstances.
With that, just before we get into resolutions then, committee, we will return to the information items found beginning on page 56, starting with the Bonnechere Manor resident statistics. Any questions, comments? Councillor Nicholson.
Thank you, Chair. And I'm trying to understand just a portion of the tables in items 1 and 2. When it speaks to respite, I notice we have 0 vacancy at Bonnechere and the year-to-date vacancy rate row, but 50% or thereabouts across the last 3 months at Miramichi. Can you amplify why? And thank you.
Mr. Blackmore, just before I invite, I'm wondering, so when we see these, is that a point in time as opposed to a indication of the monthly experience?
Through you, Chair, to answer your question to Councillor Nicholson, it is the respite numbers are a point in time. The year-to-date occupancy is running. And specific to the respite beds, throughout the pandemic period, respite admissions were suspended. It was only recently that Miramichi Lodge agreed to take on respite beds once again. It's something we continue to monitor at the Manor in terms of staffing levels. The challenge that we're experiencing right now with staffing, our focus is on our long-term care. Respite services, although obviously needed throughout the community, they do require an added level of service in that the admission process itself is quite extensive for our registered staff. So it's something we hope to return to when we're able to.
Thank you, Mr. Blackmore. Any further questions or comments on the statistics for the Lodge specifically? The Manor specifically? I see none. On to item 2. Any questions with respect to Miramichi Lodge? I see none. Moving on then to item 3, the client waitlist information. Councillor Nicholson.
Thank you, Chair. And I'm wondering if we can reserve, my question may be best answered by the Chief when he is back in the room.
Certainly.
So if we can,
we'll hold that in abeyance. I see that he has left some of his jetsam and flotsam, so he will be returning.
Thank you.
Moving on then to, were there any further any questions, Councillor Lafreniere, on item 3?
Yes, on the wait lists, when someone is from outside the county and obtains a bed in one of our homes, how does that happen? Is it because possibly they come to stay with a relative, have a brief hospital stay, and then are admitted because they're on sort of a higher priority list, or?
Mr. Blackmore, please.
Through Chair to Councillor Lafreniere, it's not necessarily predicated on it being a hospital stay. It may be by virtue of there being family member within the county.
So therefore, a family member within the county who applies would give that potential resident status? Do you know what I'm saying? Yeah, so if I'm applying for my parent who lives out of the county, that puts them, I'm just wondering how that happens.
If I could, through you to
Please,
the councillor. Yeah, the residence in the county of Renfrew is not, it's basically, if you've indicated a preference to reside in this particular home, regardless of where you're from, but the place, there's an element of influence with regard to, where you've applied to, through which placement coordination service you've applied through, but theoretically you could come from Sault Ste. Marie or the province of Quebec for that matter.
Okay, because that has been brought to me, and I believe I brought it to your attention once before, but it's a reoccurring question I get from residents in our own municipalities. Okay, thank you.
Just in following that up, and I cannot remember now the particular program, certainly you had answer to the question, but I thought that there was also, and I don't know if it actually came to fruition, that in order to free up hospital beds, they were requiring, or the listing, the prioritized listing that the applicant makes was going to be subject to availability. And in fact, there were, I know this mostly was happening, I believe, in Western and Central Ontario, but where residents might have been actually in a home that could be 100 miles away, but it was because of their priority needs and the availability of beds. I wonder if you can speak, is that program still in place, Mr. Blackmore?
I don't recall if it's in place at this very moment. It's not. It's something that neither County of Renfrew home has been affected with, i.e., residents come from hospitals outside of our area. So I kind of fell off my radar. But certainly, I just want to re-emphasize that placement is primarily based on need, your level of need. And certainly if you're in a hospital or requiring placement to long-term care, that puts you a higher level of need. So I wouldn't want to. I'm not suggesting that somebody that casually living abroad wants to reside in long-term care, that's going to be an easy thing to do. It's based on the urgency of the need.
And ultimately, the wait list, you are previously made eligible to be on the wait list to start with, and through the screening process, through the assessment, that is how one goes on the list. And of course, as Mr. Blackmore eloquently advised, it is subject to the prioritization of the applicant themselves, and every effort is made to respond in the prioritization that they may make. But of course, their needs will have an impact on that, and there is the challenge attendant on that. That the chief has returned, perhaps we'll go back then. Councillor Nicholson, your question was respect to the Champlain client waitlist information.
Thank you, Chair. I just wanted to confirm my interpretation. The 685 residents that are waiting for their first choice from within our community, how many of those are serviced by our community paramedics? And are we within that capacity, or are we underserving that 685?
Chief, please.
Through you, Mr. Chair. The funding that we received from the Ministry of Long-Term Care, not Ministry of Health, was specific to support all of the people on the wait list for long-term care within Renfrew County. So that's always a moving target, as I'm sure Mr. Blackmore would describe, in terms of people coming on the list, people coming off the list, and so on. However, at the outset of the funding and program initiation in 2021, we reached out to everyone on the wait list in Renfrew County to offer services, and then now it's really an iterative process. We have the capacity through that funding to provide some level of service to all of the individuals on that list. So if there are people that are on that list that do require any assistance from the community paramedics in terms of stabilizing their chronic disease, for example, or any clinical services, we would be an agency that they could reach out to through our 1-800 number that's available through our website. As well, we've been able to layer in VTAC services for much of that population as well that are unattached. And our goal is really, through that program, to stabilize those people's clinical experiences so that by the time they do move into long-term care, that they have a better trajectory, a better quality of life, and can fully benefit from the range of services that those in long-term care are able to provide. That being said, we also know that there are a number of individuals that are now deferring placement in long-term care because they're able to better cope at home. So we have very good linkages with all of the agencies associated with that care. Certainly, Mr. Blackmore and his leadership across the home and community care and long-term care space have been invaluable to us. But really, the opportunity here is to support the individual, but also support home and community care, support caregivers, support the palliative experience, make sure people know that hospice may be available, or what life will be like as they move into long-term care, and that they're moving into long-term care for the most appropriate time period of their life, and not simply putting their name on a list as an insurance policy and waiting for their number to come up.
Follow-up, Councillor Nicholson.
Thank you, Chair, and thank you to the Chief. I appreciate that. It's comforting to know that we can offer support to those people on that waiting list. Next question, again, and I get these questions from community members, so I'm not sure if it's who best to address the question to, so Chair, I'll leave it to you. When it comes to respite, that caregiver support, there's a increasing demand on support for that caregiver. We can't offer that support through our respite beds due to staffing limitations, and I appreciate that. Community paramedics are providing medical care or advice and counseling on where resources are, but right now there's a gap, in my observation, a gap in supporting the caregivers who are, essentially house locked to provide that support for their loved ones. How does that get addressed? Is there a lever that we can pull?
I think probably I would start with Mr. Blackmore. It's important, of course, to note that respite care is a limited duration care, even when it is fully functioning. But I think perhaps, Mr. Blackmore, you might be the best to initiate the answer to this question.
Thank you, Chair. Through you to the councillor. What comes to mind is, in terms of support for family, and when it comes to, obviously having the respite operating game would be optimal, and not every home offers that service. But something that we stood up at Miramichi some time ago was a dementia family support group that basically is an opportunity to meet on a monthly basis to discuss this amongst themselves with the support of the Alzheimer's Society. Just that, like the ability to hear each other out, listen to experts to help manage prior to long-term care admission. That group has gained, it was started probably more than 10 years ago. It's taken on a life of its own now. It's operating outside of Miramichi Lodge at present. It's independent. But it's really, aside from providing the hard service and that support that's not the same, I know, as the ability to drop your loved one off and leave and get a bit of be able to recharge your batteries, as it were, while knowing that they're being well taken care of. It's something that I don't think there's any replacement for that. And I agree there's more needed. It's unfortunate right now, the circumstances we find ourselves in at the one home. We're just not ready to pull the trigger on that one just yet.
Yeah, if I might just perhaps augment a little bit, and only a little bit, there is no question that private, and in most instances I think it's loved ones, though perhaps those with the means, may engage for hire as well, but I think perhaps the preponderance of care that are given to seniors, particularly, prior to actually showing up as a number, as metadata that we're looking at on item number 3, is through the family. And going back to your initial question, Councillor Nicholson, are they receiving adequate support? How many angels dance on the head of the pin? Probably no, but a large preponderance of care for loved ones is provided by family members, and these are at least some opportunity for them to have, precisely as it said, some respite from the enormity of the challenge that many of us have gone through and are going through in caring for our loved ones moving forward. I don't know, Chief, did you have anything you wish to add?
Thank you, Mr. Chair. Through you, I can certainly give you our view into this issue. It's commonplace for the paramedics to be called through the 911 system only to arrive and having a loved one say that they can no longer cope. That is commonplace. It's heartbreaking, and it's happening throughout our community on a daily basis. And those are the ones who have typically labored for years to care for their loved one. I don't think it's any surprise that the number of hours per person living in community and receiving care has dramatically reduced from home and community care agencies, the LHIN, as you may recall it, and CCAC and all of these other legacy agencies. And I'd look to Mr. Blackmore and his expertise in that area, but without a doubt, the per hour care per person has dramatically been reduced. The eligibility for care has been dramatically increased over the years, where it's not uncommon for us to hear, I can't cope. It's not uncommon for us to be supplementing the care with the use of community paramedics. We work exceptionally well with the Home and Community Care Agency and their partners. I think they would tell you the same things reluctantly, that they're only given so much funding, they're only given so much capacity, so much money to be able to provide services. We know that parts of this county are historically underserved, because as those calls for agencies to go out and provide care in some of our further reaches, agencies simply say, we can't afford to send a staff person out there with what you're paying us. So we see that in Palmer, Combermere, different parts of the county where there is no return on investment for agencies to go out and serve. So therefore, you remain unserved, if not underserved, for support with activities of daily living. So whether that's your grooming, hygiene, feeding, toileting, and all of these very important services that we hear about through the PSW crisis. Well, that's increasingly compounded when you have a large rural portion of the population. So I hope I've given you a bit of a sense of the challenge that's out there. The community paramedics do everything they can to plug as many of those holes as possible. I'd say one of our greater contributions is that we give caregivers the confidence to be able to keep going, and we try and give them other services that are available as the ones that Mr. Blackmore described. But this is an unspoken crisis within our community and most communities these days. And as our human resource challenges continue to increase, so too does the despair and the challenges associated with both caregivers and the people that they're loving and caring for at the same time.
Thank you, Chief. Follow-up, Councillor Nicholson.
Thank you, Chair, for allowing that discussion. I appreciate it. If I could make a recommendation that and I'm not suggesting we take on more, but if we can track this gap in terms of an unanswered solution by whomever it might be in the future as we go forward in our requirements for 2024. If there's an opportunity that we can seize, whether it's at a conference or a delegation, we need to make sure that we're sharing our stories so that somehow this gets addressed, or at least it remains recognized as an unfulfilled need in our communities. Thank you.
Just as perhaps an early attempt at this, I wonder if this is something that perhaps CIHI or ICES might be tracking. This would be a particular challenge, I think, to track, at least on a granular level. But I do wonder, so CIHI being the Canadian Institute of Health Information, ICES, I've kind of lost what that is an acronym for, but these are tasked with the repositories of data. Perhaps there might be some information available now. The challenge is, particularly for those who are not kind of in the system, as it were, that are on the long-term list, it may be even difficult to identify who those people are to be able to establish what sort of response we are able to mount. Chief?
Yeah, certainly CIHI and ISIS would be valuable sources of information. I think as well Ontario Health, based upon the number of requests for service and then those that have unmet needs, these are molars to try and extract in the healthcare system because nobody wants to tell you what they're not doing. Everybody's happy to tell you what they are doing. So I'm sure that Mr. Blackmore, I just asked Mike off the side here if that's something that we could track down together. And I think through his ministry and Ministry of Health and Ontario Health, we'd be happy to come back, Mike, and provide hopefully some greater clarity in terms of what the challenge is in the system. One of the main challenges I see in terms of gathering some of this data, apart from those who have asked for help and have or have not gotten help, because there is sort of an unmet requirement in the reporting. But this is a bit of a shadfly kind of issue where it pops up at a certain point in life and only lasts so long and then goes away, and everybody's like, oh well. But it's happening so pervasively within our communities that when you start to track that 3-month, 6-month, multiple year, depending on what wait list you're on or where you're trying to get into or what your first and second choices are, I think it would paint a different picture. So if you'll allow us at staff, just to go and have a look. Mike, do you want to add to that?
Yeah, through you, Chair. Yes, I think also we could further get a little more granular with regard to the stat that as it's represented, it's 685 residents that are either in community or hospital. So which is it? I think, and in addition to that, there are varying levels of priority amongst those 685. Are we more wanting to focus on those that are, in more urgently needing the long-term care versus the individual that's put their name down for long-term care, thinking that maybe next year they might be ready for placement? I think that would be wise for us to determine that first. And the CIHI, we could look. I certainly have access to the CIHI database. It's not a stat I've seen with regard to, that granular of a number for our county or for the province. But yeah, we'll certainly see what we can find out. But I think it would behoove us to narrow this down from the 685 to start. And yeah, and in terms of the challenges, Mike had mentioned health human resources, and we all know how challenging it is. I alluded to that right now, where we've got staffing agencies and look at international nurses for the manor. Well, home health care it's even worse. And so, it adds to the challenge. That you may well have the service of the funding and not have the staff member available to go to wherever. So, I think, again, just to repeat, I think we need to narrow this 685 number down a little further first.
Just while the directors were answering that, I just brought up, and I can't actually find the data, but I know that this data is available. I don't know who would be the custodian now. The last of the Champlain Lynn performance reports that I have is from Q2 2019. Of course, there was the transformation to Ontario Health and Ontario Health teams from the Lynn model, but ultimately this was being tracked. I know that they had data points that were precisely that of how long from the time that this would be a non-list worthy, like someone that is not eligible for long-term care yet, but how long from the time that they would have been made eligible for a certain level of home care before they would receive that first one, and what was the level of home care that they were receiving in relation to what it was that was essentially prescribed, if you will. And I know that the Champlain Lynn, through I'm sure the CCAC, was tracking precisely that data. So I don't know who, as I said, would be the custodian of that information now. Perhaps it is Ontario Health, but I think that it's probably available.
Through your chair of the committee, so we generate this document is generated from Champlain Community Healthcare Services.
Okay.
So they've kind of modified this for us because a while back, you recall that we wanted to know, we're tracking first choice homes to delineate the total number of people awaiting placement, because the previous numbers were you could have one person counted 3 times because they've asked for 3 different homes. So I think if anyone's going to have that information, it's going to be the service. We have a contact.
Thank you. Councillor Lafreniere.
So just further to that, I guess the question, the interesting part of this would be how many on the wait list are actually living with a family member receiving support. And the reason I'm saying that has importance is because if those services were available to those families that are caregivers, perhaps they would refuse the call when they get the call saying, you know, we have a bed. I know from personal experience, I had my grandmother living with me 30 years ago. I still had 3 young children at home, and it was quite stressful for my family at that time. She'd had a stroke, she had mobility problems. I was receiving respite 1 day a week where I could go out and with my children, my family, and spend the night at the trailer and then come home Sunday. So I don't know what I would have done if I would have got through that period of my life caring for my grandmother had I not had 1 day a week where I knew I could leave with my family. So what I'm saying is, how many I think that would be a good starting point, is when someone's applying, are you living with, are you living with family members getting support? Because if you reach out to those, that's a preventive measure on seeing who actually ends up needing a bed. So I think that might be a good place to start.
Thank you. I think we can take that under advisement and bring some information back to a future meeting. Mr. Blackmore.
Thank you, Chair. And Councillor Lafreniere just reminded me that we were discussing earlier what potential avenues are out there in terms of respite. And in my mind, I was thinking overnight respite, but of course there are day respites as well available throughout the community that provide, just as you explained, that day's reprieve. So I did want to thank you for that.
Thank you. Moving on then to item 4, the revised masking requirements. Item 5, the Treasurer's report for Bonnechere Manor and Miramichi Lodge. Any questions, comments? My question, I think it is, I think I have it on repeat. I know the answer, but I think it is still worth having it for the recording that is on YouTube. It is for the extra hours of care. You'll find that, where am I to be finding that? Mr. Blackmore, I know that you and I have chatted about this often, so you probably know the page that it's on, but I just wonder if you could speak to that again. It's a revenue line for the enhanced care that we heretofore have been unable to access.
Thank you, Chair. I don't have the dollar figure in front of me, but I know it's significant. And that's funding we're provided by the Ministry of Long-Term Care to get us to that goal of 4 hours of care per resident per day that we have not been able to utilize fully related to recruitment challenges at present. We have seen an increase in that hour number over this past year.
64.
64.
It's on page 64 in grants and subsidies. That's where you'll find it. We are eligible for nursing staff supplement over the year of just over $2 million, and on the allied health just under $300K. And to date, we have not utilized any. That's where the actual line items are contained, is on page 64.
Yeah,
what I was seeking was just the challenge in that fund has been somewhat elusive for us to access. I wonder if you could speak to that.
Correct. In terms of being able to hold on to that funding, you have to demonstrate an increase from your base funding before this fund was initiated. Yep.
Okay. And I think that is worth repeating for committee, is the ongoing challenge that we are experiencing. predominantly driven by staffing, health human resource issues. But nonetheless, the holy grail that had been sought in long-term care was the 4 hours of care per day for at least as long as I have been a member of the county council. I think it's probably 20 or 25 years that was established as the goal that we should be working towards, and here we have achieved it because of the challenges, the staffing challenges that we're finding, which in fact speak to that conversation that we just finished with respect to home care, et cetera. But that continues to be a substantial challenge, more so at the manor. I do note that we have been able to utilize some of those funds at Miramichi, so very pleased at being able to do that, but it certainly speaks volumes to the carrot is there. This tantalizing dollar figure is there in front of us, and yet to try as hard as we might, we are challenged to find that. So anyway, I just wanted to speak to that on that. Are there any other questions or comments on the Treasurer's report? Councillor Nicholson, please.
Good. So just so I understand this in layman terms, there's $2.3 million available for us to support our long-term care. We can't access the $2.3 million because it's restricted in terms of what we can use that money on, people, and we can't find people.
Through your chair to Councillor Nicholson. So we have been able to utilize a portion of it. Like you can see at Miramichi Lodge, direct care, we're underspent by, I think it's $400 and some thousand. But you're right, that's the reason for not being able to maximize, fully utilize the funding is the inability to recruit the number of people required to use up those hours.
It should be kept, we'll come back to you momentarily, should be kept in mind. I'm not sure how it can be recognized, because you will also see within the manor, this is on page 59, with respect to nursing services, you will see right near the bottom, purchase services and purchase services accommodation, which are pretty substantial. It is in fact over $2 million that we have expended on purchase services as opposed to direct nursing care. How does that fit into the equation, if you will, Mr. Blackmore, if you understand where I'm coming from?
Thank you, Chair. And that's just the use of the agency staffing and all that's associated with that, i.e. the accommodation, mileage, and the rest of it, speaks to the inability to fully recruit the staff, permanent staff, required to fill those spaces. So you'll see that in the direct care line at Bonnetry Manor as an expenditure, the dollar figure is closer to what's budgeted, but that's largely a result of not number of staff hired, it's the expense of those staffing agency staff that are paid at a higher rate. And the for whatever reason, well, the challenge with recruiting permanent staffing at the manor, the proclivity of this staffing, people going to staffing agencies is a bit of a conundrum for us in terms of, they're paid at a higher rate, and obviously you could see where that would be an attraction. But yeah, we're really kind of at a loss. We pulled all the stops with regard to various recruitment, retention strategies, both provincial and our own homegrown ideas, from retention bonuses to international recruiting to referral incentives, participation in every provincial fund that's out there. We're hoping that our most recent endeavor, the 20 international staff that we've got coming on board in January, we're hoping that's a start of maybe something that comes to fruition in greater numbers.
Thank you. I think you had a follow-up, actually, Councillor Nicholson.
No, I'll give the floor there to Pembroke, please.
Okay, thank you. Councillor Lafreniere.
So if you could just do a quick description. So when they say 4 hours of nursing care, like to increase that, what types of things would that increase for the patient, nursing care? So I know there's the administration of medication, things of that nature. Is that strictly nursing, or would that be also the PSW work?
Through you, Chair, to Councillor Lafreniere, that's direct care, so that could be PSW, RPN, RN.
Okay, so all of those services. Okay, because I was just trying to think like a little out of the box, and like how could we maybe recruit individuals that have those skills that aren't necessarily under the title of nurse, et cetera, et cetera. I know my husband was in Toronto Hospital for a couple of months. He used to call it the babysitter, but it was someone who was not certified in Ontario. They were from another country, but they sat there all night with him and just sort of monitored, you know, and it was giving him care of somewhat if he needed something to drink or something. So that's all I was doing, was trying to analyze what exactly that care would consist of, and could we mold it to have other individuals providing some of those services. But the answer obviously is no. So thank you.
Okay, thank you. Councillor Nicholson.
Good, thank you, Chair. My whole point on this is that the province has set money aside. I'm assuming it's use it or lose it money. We have to give it back. We can't spend it in the terms and conditions that they've outlined due to constraints that we cannot resolve. Can we go back to the province and say, can we use this money in another way to increase our level of service? Like, why just turn back this money that could go to the benefit of our community members in some other way? If we just need to pull a lever with the province, can we not try?
I'll take the first stab at that. I think that is something that would behoove perhaps me in my role as chair, perhaps inclusive of the warden, especially, and in fact, Councillor Murphy, through Roma, through AMO, et cetera, that these challenges are real, and they are in fact constraints. They are impairing, you know, the thriving of what we hope to do. That I think that advocacy probably it behooves us on this side of the room, as opposed to staff, to be moving in that direction. With that, Mr. Blackmore.
Thank you, Chair. To the committee, I mean, when we approach baseline, the expense of, not that we want to perpetuate relief staffing agency staffing forever, but in terms of cost, we've covered that cost through the Safe Start Fund, I believe it's called, Daniel. But approaching baseline, I think our look will be to that supplemental funding to keep staff, hire staff. Does it move beyond just the hourly wage, or are we able to incorporate the costs associated with keeping those staff, i.e. the mileage, the enhanced rate that goes to staffing against that fund? That's a question I think probably more for Daniel we'll have to explore, but as we approach baseline. Okay. And in terms of, if I could, just, you know, the opportunity to utilize funding for something else, it's the Ministry of Long-Term Care, we've got so many envelopes of funding that it's crazy to even try to keep track of them. There's just so many, but they are very prescriptive. So when they say, you know, supplemental funding is intended for PSW, RPN, RN direct care, there are other funds that speak to some of the other staffing challenges by way of things like allied health that are very specific to us. They identify who the allied health professionals are, with that physio, IPAC. Anyway, my point is, it's just they're very prescriptive, but it's not to say that that's something I know our own not-for-profit advocacy agency, Advantage Ontario, has brought to the attention of the province on numerous occasions. Can we please consolidate these accounts, these funds, to be a little more, give us a little more flexibility. And there has been success over the years with some of those types of funds, but usually it takes a number of years. But we have example, there was a fund at one point called the RPN fund. And regardless of the number of RPNs you had in your home, for which Miramichi Lodge was among the highest in the province, we had 1 RPN per 27, the ministry says, here's more money for RPNs. We don't care that you need more PSWs. But anyway, that just as an example, that was one that we're actually, with some advocacy, we're able to change. But
thank you, Mr. Blackmore. It is an imprecise environment that we inhabit with respect to this particular question. But I think that probably is something that we should take it upon ourselves in advocating on behalf of the homes, but of course more so even the residents. Any other items on the Treasurer's report? That's where we're on. We're still on the Treasurer's report. I see none. I think there was one more item. Just bear with me as I return to my report. Of course, very pleased to follow that up with the enormous congratulations to Mr. Blackmore and his staff. Much appreciate the shout out that he was providing to the warden and myself, who took it upon ourselves for a grueling hour and a half, I guess, meeting. That was my muscular participation in this process, as he had appropriately recognized it is the staff each and every day in our long-term care homes that are always striving for excellence. And this accreditation with exemplary standing is the recognition that that is what they are doing, and they are achieving that. So enormous congratulations and commendation to Mr. Blackmore and all of his management staff and all of his staff broadly for the incredible effort that they bring to bear. And it is, you are seated now in the room for the first of the joint accreditations. Each of our individual homes were receiving individually this accreditation, but very pleased now as we are moving forward, and I believe this was part of our strategic plan, if not this, the one we are currently in, the previous one, to bring into alignment our services. So enormous congratulations to everyone at Bonnechere Manor and Miramichi Lodge. Any further question or comment? I see none. So with that then, Mr. Blackmore, moving on to resolutions, please.
Thank you, Chair Donahue. Through you to committee, number 7 is a resolution for leased space for the second floor of Miramichi Lodge. A recommendation that the Health Committee recommend that County Council authorize the Warden and the Chief Administrative Officer Clerk to sign a lease agreement between Miramichi Lodge and Ms. Brenda Kincaid, foot care service provider, Miramichi Lodge, for the occupancy of a leased space room within Miramichi Lodge located at 725 Pembroke Street West, Pembroke, Ontario, at an annual amount of $4,764 for the period of January 1, 2024 to December 31, 2024. And further that a bylaw be adopted at the next session of County Council.
Thank you very much, Mr. Blackmore. I would now seek a mover, please. There we go. I was looking on the little screen here, you see. Moved by Warden Emo, seconded by Councillor Weir. Background, please.
Background, Miramichi Lodge was designed to include additional space to lease in order to generate revenue. Ms. Brenda Kincaid, foot care service provider at Miramichi Lodge, currently leases the 240 square foot space located on the second floor that provides foot care services to external clients. Ms. Kincaid has indicated that she wishes to continue to lease the space for a 12-month term. The County of Renfrew Development and Property Department has assessed the area and determined a fair market rent would be a 2% increase from the last agreement, which in 2020 was, with the reprieve during the pandemic, for an annual amount of $4,764, payable in monthly installments of $397. Attached as Appendix Long-Term Care 2 is the lease agreement and bylaw.
Thank you. Any questions or comments? All in favor? That is carried. Thank you. That is okay. It is carried by these folks here that are also behind each of you. I'd now seek a motion to approve the long-term care report, please. Councillor Murphy, seconded by Councillor Frenier. All in favor? That is carried. We are going to plow through as Councillor Giardini will soon be evicting me from this seat. Mr. Kelly, the admin report, please.
I can officially say good afternoon, committee. Thank you very much. That was thank you, Chair. So my report's on page 79, but before I go into the budget recommendation, or before I end the recommendation on that page, I'll give a bit of a background on why we're doing what we're doing, and apologies or not to those that heard me yesterday. So we're taking a bit of a different approach, and hopefully engaging you in this discussion today is as we set our budgets, and Mr. Blackmore and Chief Nolan are busy setting their budgets with finance at the moment. We wanted to highlight some of the activities from 2023 in terms of accomplishments, and they will form part of a larger document that will be coming before you in the next month or so as a report card to County Council on their strategic plan. But to point to 2024 actions or items that both departments are looking at for 2024, essentially collaborating with you to make sure we're on the right track or on the right path, right trail, moving forward into 2024. So, as I noted in the report, this interaction between staff and elected is important, just to be sure that we're not missing something that you want to see. Regularly, these reports come to you by recommendations with staff, and I have, as I'm sure you do, have full confidence in staff that we're finding innovative and new approaches, but didn't want to be missing out on those 2024 actions that you may or may not want to see included prior to our budget workshops. So with that, Chair, the recommendation for this this conversation, before I read the recommendations, after I get to the recommendation, I will ask that each department head will lead you through a quick little synopsis of the 2023 and 2024 action plans. So,
I am probably given to allowing that as well.
I'm sure you will. Thank you, Chair. So the recommendation that I've put forth is that the Health Committee directs staff to bring the business plans for all relevant divisions under the purview of the Health Committee to the 2024 budget workshop and planning meetings, including any suggested revisions or conceptual projects or areas of concentration. Thank you, Chair.
I'd now seek a mover, please. Councillor Weir, seconded by Councillor Wilmer. With that, I will return the floor to you, and you can provide the floor as you see fit, Mr. Kelly.
Thank you. I'll look to my colleagues and see who's ready to knock off their bit of the business plan. Perhaps Mr. Blackmore, I'll start with you. I point to the finger. I asked first, and then I told later. So if you can just, it's kind of my role. So if you just want to, unless the chief is ready. All right, I'll go to the chief first, then Mike. That's fine.
All right. Thank you, Mr. Chair. In terms of the departmental overview...
It's on, sorry if I might, Chief. It's on page 80 is the Emergency Services Business Report. That's a good place for committee to join.
Thank you, Mr. Chair. In terms of the departmental overview, and I think in the interest of time here, I'll skip through this fairly quickly for you. Our population is roughly the same. Our geographic area remains certainly a challenge to be able to cover off. But just to highlight in terms of our mission around continuing to provide services to the residents and the visitors of the region. When we think about what the paramedic service is, it's certainly evolved over time, but really it's evolved commensurate with the needs within our community. We provide an overview for you of the 911 operations, CR team, community paramedicine, as well as specific programs funded by government, being the Community Paramedic and Long-Term Care Program, the palliative care initiatives, remote patient monitoring, and of course the VTAC program, which we've taken a bit of a deeper dive into today. The statistics provided within the report, I think, give you a good overview around the activity, and to highlight for you some of the achievements. Certainly, the addition of 2 12-hour vehicles beginning last July was very helpful, supportive of our goals in terms of being able to cover off significant increases in demand for service across the area, but also being able to deal with some of the pressures within the system. One of the upcoming things that we're really looking forward to and working collaboratively with Development and Property is the upfit of the Eganville paramedic base. So thank you to everyone for their support in that part of that process. As well, AMPDS, and this is something we haven't talked a lot about lately, but through AMO, Roma, and all of the organizations, including the UAPC, we've been petitioning the province to modernize the dispatch system for paramedic services across the province. We're very happy that Renfrew County is among the top 5 to be implemented in the province. Mississauga, Kenora have already begun and at different stages of implementation. We're expecting that by March we'll launch with Renfrew Central Ambulance Communication Center, and that's huge that we're very near to the top of the list for implementation across the province. So a big thank you to the province for that. But with that comes other opportunities and challenges. So while it's going to change the method by which dispatching occurs, it also creates an opportunity that the province is now allowing us to have a commander in the dispatch center, working shoulder to shoulder with the dispatchers to be able to support some of the operations. Many of the items are also about cost mitigation, so we can now have a commander in dispatch to help with end of shift overtime issues, which historically I have said have been outside of our control. Having a commander in dispatch can allow us to be able to advocate for our staff, but also be able to use the resources within the system, as well as managing issues of lunch, optimization, workload balancing and sharing, and so on. As well, we've achieved a novel funding agreement with the province for the VTAC physicians and the IVC program that you heard about today. As well, the creation of a Community Health Program Advisory Committee, which was approved, and we're looking to the new year to launch that with the new constitution of committee structures, striking committee, and so on. So we'll be moving forward with that in the new year. As well, working closely and monitoring closely the issues related to mental health addictions and homelessness. And as you know, we've submitted a draft terms of reference to committee to be able to move that work forward in parallel with the budget process. And then lastly, we did conduct an emergency management review and exercise. So when we look at 2024, Mr. Chair, looking at considerations and opportunities, we need to improve patient flow. So we have now received funding from the province for the dedicated offload resource. So that's a fantastic opportunity, and we'll continue to work that through. Improving response, we'll be implementing the other half year worth of staffing. So that does come with a financial pressure because last year we only budgeted for 6 months. This year we'll be budgeting for the year, meaning an additional 6 months. So there's a cost impact through the budgeting process for that. We will be seeking as well support for having a commander in the dispatch center. So that will be a business case coming forward as it relates to the costs associated with having that commander in dispatch. We know that there are hundreds of thousands of dollars to be realized through end of shift overtime, lunch breaks, and optimizing the service. So my goal is to be able to implement a commander in dispatch. And of note, we're the one of 2 in the province that have been allowed to do this. But there is a cost to us in having a commander in dispatch. That can also assist in issues of interoperability with the fire services and so on by having a commander there and reducing any time delay or coordination related issues. We also have an issue that came out of the job evaluation process a few years ago, and we have significant compression whereby our commanders are now making more money annually than my deputy chiefs because the commander's salary on an hourly rate was appropriately evaluated, but the commanders work 42 hours a week where the deputy chiefs work 35 hours a week. So it actually has created a significant challenge from a recruitment retention perspective, which is one of the reasons that I've not yet confirmed the 3rd deputy as part of my model because of this outstanding issue. As well, improving labor relations. We have a collective agreement to be negotiated beginning next month, and as well expanding our CVTAC. And we talked a bit about that and where the pressure points are for both the VTAC side of the house as well as the IVC component. So what are we looking at? Getting the Eganville base up and running. And big thanks to Jason for helping us with that. Improving access to mental health, addictions, and homelessness. So what does that model look like? By having a community paramedic and likely a partner from community and social services working together, leaning in population health model, but also having the ability to support other mental health related issues through the 911 system. So I think taking a hybrid or a dual role as we do in all other areas of our community paramedicine represents an opportunity, but it also represents some challenges. So we are partnering with our Ontario Health Team partners to put an application in, but that will be likely the latter part of next year before we hear back. And we know we have an issue now. So I think we need to look at this in a two-phased solution model for the county as a whole. So we're working that through as part of the budget process. Strengthening relationships with Ontario Health Teams, and happy to say that Ms. Jama Watt, the Executive Director of the local health team, has been provided space in this building to be able to support her work and include her more closely with staff who have an Ontario Health Teams connection. And then strengthening community resilience through our emergency preparedness application that I spoke to earlier, Mr. Chair. So from there, I'm not sure what to do here, Mr. Kelly, whether you'd like to turn it back or head directly on to Mr. Blackmore.
I think that we will go directly to Mr. Blackmore, and this is on the next page. Beginning on page 87 is the business plan for both Monasher Manor and Miramichi Lodge. Mr. Blackmore, take it away.
Thank you, Chair. Through the committee. So just briefly, the departmental overview. So both homes, Miramichi Lodge, are the largest employer for the county, for 500 plus staff, to 3 unions, $37 million a year budget. We provide 24-hour care that's at leading edge, has been for some time. With our, we're engaging in practices that are, for the most part, may have been practiced in chronic care hospitals versus long-term care. We have a long history of nurse practitioner involvement at both homes. Our mission with a person-centered approach, Monasher Manor and Miramichi Lodge is a safe and caring community to live and work. 2023 achievements, as we just alluded to, we achieved our accredited with exemplary status standing as a joint homes with the participation of key stakeholders and certainly staff. As part of that, maintaining high standards of care and also our physical environment. So we, along those lines, we achieved some significant capital projects, including upgrades to the HVAC system at Monasher Manor as part of a multi-year roofing project. At Miramichi Lodge, capital budget projects included upgrades to our generators, the nurse call system, and HVAC as well. Of significance, the Fixing Long-Term Care Act brought in a whole host of new regulations for both homes, one of which is being emergency preparedness. So both homes are required to practice a number of codes on an annual basis and attest to their completion and also review the outcomes of those. So those were completed this past year. And I know we spoke a little bit to some of the challenges with regard to recruiting and retentions for our direct care, but we do have some good news coming out of this past year in terms of allied health, in that we were able to secure a nurse practitioner, one for each home, which was very much appreciated by all, particularly our residents, with regard to the level of care that they can provide. So yeah, very fortunate that way. We each were able to secure our own infection prevention and control nurse leads as well. And in addition to that, we were able to hire a social worker, one for each home. So all very, very welcome additions to the home in terms of improving the quality of care for our residents. As alluded, we certainly have run into some staffing challenges, but we've engaged some what I think are relatively, we've certainly taken advantage of the various opportunities afforded us by the province. In addition to that, we've engaged our international recruiting of nurses for Monasher Manor, like I'd mentioned, 20 slated to come on board in January. We've also made some enhancements to admin function at both homes, where we once had administrative supervisors that had dual roles at both homes, primarily that of being a liaison to finance and human resources. And over the years, we found a particularly challenging portfolio to fill, someone that's expert in both those areas. So, and that we've identified having two individual people doing those particular roles in both homes, we found a number of discrepancies in terms of process. So we've engaged in modifying the AS position such that they're more focused on finance, one person for both homes, and a human resources coordinator that is focused on human resources for both homes. And keeping in mind, obviously, we have a human resources contingency at department rather here at county. So that HRC person that's dedicated to the homes has a direct line to the HRC department in terms of maintaining consistency approach and whatnot. But at the same time, having someone physically at the homes that have a better appreciation for the operations. And that was achieved at no cost, or actually was a savings to the county. We were able to successfully negotiate a collective agreement with our QP locals, 1508 at Renfrew Lodge, at the Manor, and 3586 at the Lodge. And our butterfly model of care efforts, I know you've heard that name for some time now, and certainly before the pandemic, a number of elected, you will recall having visited the butterfly home at Peel. Unfortunately, it was put on pause over the pandemic period, but we've since restarted, and we're well underway at the Lodge, certainly, in that training is being completed, and we hope to achieve our certification this coming February. Environmentally, both homes have underwent quite a bit of transformation on the affected units. Given the staff and challenges that are underway at the Manor, we've had to modify the training and delivery as we want to train our permanent staff versus invest in agency staff. So we've adopted a modified version of Butterfly just to keep us active, but not necessarily ready for certification. It's termed the Chrysalis project. Opportunities for 2024, so just taking from the corporate strategies, fiscal sustainability, tying into that from the homes perspective, we want to look at ensure our asset management plan and long-term financial plan are sound. Just in keeping with operating two large homes with large pieces of equipment that are aging, to make sure that we're maintaining the maintenance that's required to keep us operational and prevent emergency repairs at a later date. Workforce development is a Renfrew County of Renfrew objective for the strategic plan was to collaborate with high schools, colleges, universities to have students with skills that are required. So for the homes, from a health human resources perspective, just recognizing the challenges, we're going to be doing all that we can to be even more innovative with regard to recruitment, retention, as I mentioned before, the international placement, really bolstered by what we're hearing from Algonquin College, their recent presentation, identifying the once stalled PSW programs have had some life breathed back into them, in large part due to the international students that are coming. So we're looking to tap into that, potentially maybe be able to get our in-home classes going again. That's something we'll explore with the college. We were able to do so previous to the pandemic for both the Lodge and the Manor, so hopefully to revive that. So yeah, that's essentially our number one priority right now. When it all said and done, it's that recruitment element to get to where we need to be. And just in keeping with the international, so we utilized some funding from Safe Start to help fund that, getting those international candidates here. So we want to explore, is there any opportunity for us to do something, what part of that internally can we do to help mitigate that cost, if anything. So proposed projects for 2024, again, just going back, recruitment retention, number one, those strategies I'd mentioned previously. We'd also on our radar is the First Nations, Inuit, Métis, and Urban Indigenous, and equity, inclusion, diversity, and anti-racism requirements that are going to be upon us this coming year to make sure we're providing the training necessary to satisfy that requirement. Butterfly approach, as I'd mentioned, hoping to get certified at the lodge for February, and hopefully, pending getting the required staffing, permanent staffing that is, at the Monastery Manor to ramp it up for the Manor as well. Continue to promote home policy, procedure consistency and alignment. So just to make sure that we're maintaining consistency with regard to approach, policies, procedures, how we manage any range of things. Make sure that we're not doing something at one home that gets pointed out as to why you're doing it that way at one and not at the other, where it makes sense that we should be doing that. And as part of that, we'll be looking at implement an electronic policy platform to help facilitate that process. And just as the County of Renfrew has a strategic plan, the homes have long had strategic plans as well of their own, specific to the requirements and the feedback we received from our family councils, resident councils, staff, specific to the operations of the home, that obviously we want to dovetail into the County of Renfrew strategic plan. But this County of Renfrew strategic plan alone doesn't provide. It's more broad. We need to get down into a little more of the nitty-gritty of what's unique to long-term care. So we're coming into the last year of our 6th year this year. So part of that will be planning for strategic planning exercises for the upcoming year, for the next 5 years.
Thank you, Mr. Blackmore. I wonder, Mr. Kelly, did you want to knit those threads together before I call the vote?
Yeah, no, I thought, and thank you very much to the Chief and to Mr. Blackmore. What I would suggest, and I'm sure you will, before you get to the vote, is reach out to committee to see, again, are we on the right track? Is there something we're missing? And is something else that we need to build into 2024 as we move forward to the budget workshops in January?
Thank you. Capital suggestion. I don't know, certainly, committee, if you have anything that you have been ruminating on, that you have been giving consideration to, now would be your opportunity, though I would, in fact, suggest that the budget workshop will be available for discussion. We are, in fact, at our last committee meeting of the year, of our inaugural year, if you will. You will note back on the initial agenda page, it says the next meeting, but the next meeting will in fact be at the call of the chair. So I just wanted to apprise all of the committee that this is, in fact, the final committee meeting for the Health Committee as it is currently structured, potentially, for 2023. But the floor is open if there is any suggestions. Councillor Lafreniere.
So as representatives for the city, we are not involved in the budget workshops. So that's why I'm sharing my thoughts right now. In regards to the paramedic service, I know that you're delving into new territory with the mobile mental health addictions homelessness hub, as well as this. So I'm looking at proposed projects. I just wanted to inquire, and possibly Mr. Kelly could give me some insight. I know recently the county approved an ad hoc committee being formed for the warming center / potential shelter. And I'm wondering if it would be advantageous to have representation from the paramedic service, either the chief or a designate on that committee, because they're the boots on the ground. And because they're also moving into that scope, it might be beneficial to everyone to hear what their opinions are as in terms of outreach. I know their outreach in the community could be, also saying, this is how many individuals are out there and are looking for shelter. So I'm wondering, that would be my suggestion, is to include that in the projects or the involvement of that department. I don't know. I know they're busy. I know I'm not trying to add more work, but certainly, as I said earlier in the meeting this morning, is that anything that Chief Nolan has any input into seems to benefit. So from his expertise and his empathy to those individuals. So that's something I wanted to see if it could be included. And that would be it for me. Thank you.
I will come momentarily, Mr. Kelly. I do note your hand in the air. Of course, who can resist the mellifluous breviloquence of Chief Nolan? I would suggest, however, two things. First, I want to be clear that we can certainly give consideration to a shelter. That is not before the ad hoc committee right now. We are looking at a warming center or I believe that it is tasked, Mr. Kelly, correct me if I'm wrong, but I believe its task is for the current winter season to ensure that we get from this season into spring, and then we will have a discussion. So I do want to be careful of that. What I would suggest is and I believe that the ad hoc committee reports up through health and community services as well. Thank you. What I would presume is that staff, any of the staff as resources, will be available to the committee moving forward, that it would be inappropriate having staff on a seat on a committee, that this committee is struck as members of the governing bodies of Laurentian Valley, of the City of Pembroke, and of the County of Renfrew. But certainly any staff resources that the committee would see fit to avail themselves of, I'm sure would be made available too. Mr. Kelly, you wish to add anything?
No, Chair, and that was worded as you've mentioned in the report, that staff would be allocated as appropriate when and where necessary. So you're entirely correct.
Thank you.
Thank you. So yes, also the services of Ms. Lipinski would be greatly appreciated too. So thank you. Just noted.
Thank you, and thank you to Mr. Kelly. I am typically more like 75, 80% correct. I think that's the first time I've ever been entirely correct. Any further questions or comments? And once again, as I am suggesting that we are not in a forever hold your peace, the process will be going forward. So if there is something that you deem to be appropriate and pressing in our communities as it pertains to the Health Committee and the role filled through the Health Committee in the services of long-term care and emergency services, there will be further opportunity. Seeing none at this point, then, I will call the question on the resolution before us. All in favor? That is carried. Thank you. With that, then, you will find as the last item on page 9.
I would suggest, sir, the report as a whole.
Oh, sure, even though there was only one item on the report. Always with the homework, so the entirely just fell completely apart right there. Anyway, briefly, I was at the top of the mountain. Can I have a resolution, please, to approve the report as a whole? Councillor Purcell, seconded by Councillor Murphy. All in favor? That is carried. Thank you. You will find the minutes of the regular Board of Health meeting for Tuesday, September 26th, attached to your reports beginning on page 94. I would now seek a motion to receive said board minutes, please. Councillor Weir, seconded by Councillor Grills. Any questions or comments? Councillor Nicholson.
Thank you, Chair. And I mentioned this before, but I'd like to recommend that we invite the Medical Officer of Health to come and discuss the opioid crisis here in Renfrew County. I acknowledge that this is the last meeting of the Health Committee, but maybe there's another opportune moment where he could come and share the dire straits that we're facing. Thank you.
I think that is an outstanding suggestion. Unfortunately, I don't think that the dynamics of that opioid crisis that is in our communities is likely to abate in any sense, so I expect it will be just as timely at the next meeting or the appropriate next meeting of the Health Committee. I will leave that to staff, but I think that is an outstanding suggestion. Mr. Kelly, Chief Nolan.
If I could, through you, Mr. Chair. Dr. Morgenstern was invited to attend today. He is on vacation leave at this time and wasn't available, but did send his regrets and seemed quite pleased to have been invited to come. So I'm sure we'll see him early in the new year.
Thank you. Anything further on the minutes before us? Seeing nothing, all in favor? That is carried. Thank you. Is there any new business this morning? I see none. Mr. Kelly, there was no requirement for closed meeting at time of mailing. Has that changed?
It has not.
Thank you. As I had noted earlier, the next meeting will in fact be at the call of the chair, given that at the inaugural meeting, which I understand, I believe, is December 12th of this year, wherein the warden will be elected/appointed, and at the discretion of the warden, the chairs will be struck, and then from there, the meeting will be held. So at the call of the chair, with that, I would seek a motion to adjourn, please. Moved by Councillor Purcell, seconded by Councillor Grills. All in favor? That is carried. We are adjourned.